everybody see? Yusuf, can you see my screen?
Yep. Yeah, you're good.
Great. And can everyone hear me? Okay.
Yeah.
So we'll get started. So my name is Daryl Goldman, and we're doing, this is just an introduction talk to interventional radiology and minimally invasive procedures. So how to see? Okay. So I have no disclosures. So first of all, what is interventional radiology? And I'm very excited to be able to share this introduction because I love the field. So this is a great slide that just sort of shows everything that IR can accomplish, and that it's such a cool field because it really is something that we use to treat everywhere in the body. So you can see here we do, we do a lot of liver work, we do stuff in the lungs, we do interventional spine and MSK stuff. We get to work in the legs, the prostate, the uterus, and do a lot of GU interventions, which is a very new and upcoming exciting field. And you can see that there's, everything that we do is on this slide. So I'm going to get into it more now as we go. So IR really revolutionized medicine through the use of image-guided, minimally invasive therapeutics. We can both diagnose and treat, which is really exciting. So we get really good skills in diagnostic radiology, which really helps us when we are being clinical interventional radiologists so that we can evaluate patients and decide the best options for management. We are a collaborative field with almost every service in the hospital. This is the future of medicine really is less invasive means for treatment, and that's where IR has revolutionized medicine. In 40 years' time, our current technique will probably be prehistoric. We're always very cutting edge. So IR and also interventional neuroradiology are pioneers in the field of medicine. So we have novel procedures, device development, and evidence-based practice. And device development, if anybody's interested in that, is something that's very exciting. And IR is always really on the cutting edge and in the forefront of this. It's a very varied specialty, both interventional neuroradiology and IR. So like I said earlier on the previous slide, we work in the brain, the head, the neck, the spine. We do pain interventions, oncology interventions, all over the body. As an IR, you are really a clinician, a proceduralist, a researcher, an innovator, and an entrepreneur. And there are really opportunities to work in all of these. The primary difference between IR and surgery is the utilization of advanced imaging to guide intervention. So we use various different imaging techniques. We use fluoroscopy, we use digital subtraction angiography, ultrasound, we use CT, we use cone beam CT intraoperatively, and we also use MRI. So we'll get into this probably more later on, and I don't want to spend too much time on the actual tools of the trade because we have so many, and I don't want to bore you, but the Seldinger technique is really where all of this started, and it's basically using a needle to get into a vessel, and then through that needle, we'll place a guide wire, and then over the guide wire we can place a sheath, and then through that sheath we now have entry into the vessel, either a vein or artery, and through there we can put our catheters, and you can see various different catheters with different shapes which make them easier to access certain vessels, and then we have a ton of different other tools. We have stents, we have vascular plugs, we have coils. And again, we use the different imaging guidance to access these areas of the body. And we have catheters and microcatheters that help us with navigating to the certain vessel that we want to treat. And then we have different embolic materials. We have glue, particles, coils, onyx, and gel foam, which are liquid embolics as well. And then we use balloons for angioplasty or venoplasty, and then stents as well. And then, like I said, the plugs. So the history of IR really began in 1953 with the Seldinger technique, as I described earlier, and it was really introduced to replace surgical cut down for angiography. Dr. Dotter in 1963 used serial dilators to treat femoral artery atherosclerotic lesions. And then in the mid 1980s, a wide array of therapeutic interventions and devices had been developed. And this is where IR really entered a golden era, transitioning from diagnosis to therapeutics. The nature of IR really lends itself to innovation, as I said previously, working in small places without direct contact visualization forces creativity and the creation of new devices. So here's just an example, and some of you, as I've noticed, medical students these days that are interested in IR really know a lot. So this is probably pretty basic for you guys, but this is just an example of angiography. So here we can see the aortoiliac arterial system here, and this is angiography, and then we can see also angiography of a kidney here on the left, or the right side of the screen, radiology left. So again, this is sort of a historical timeline that I said previously, but it's showing, you know, that it initially started in the 1920s with surgical cut downs, and then our devices sort of advanced over time, and then we were able to start the Seldinger technique, and now we have, you know, C-arms and fluoroscopy machines, and we're able to do a lot more. So now, you know, even there's more even on the future. So in the future, there's actually the first in-woman experience with the use of robotically guided catheters to accomplish embolization of uterine fibroids. And that's pretty exciting, and it's on the horizon. 5 women actually underwent this procedure with a robot, and there was complete technical success in all patients. And this is sort of a video. I'm going to skip this in the interest of time. So again, this is also a sort of a historical timeline showing that our angiographic catheters have really advanced since since they really first were conceptually thought of. And now we have microcatheters, and we have steerable microcatheters, and we have catheters that really can go to anywhere in the body. So this is again showing that these angiographic images really show that we have different shaped catheters, and this is a microcatheter that can get all the way out into this tiny vessel out here, which is really exciting and new. And then this is a video showing the navigation of a steerable microcatheter as well. This is another future, well, actually it's already being done, but this is percutaneous dialysis access. So in the past, surgical options for AV fistulas for dialysis were always made with a cut down, and you know, the artery and the vein were anastomosed into the AV fistula. And now we actually do this endovascularly. So these are percutaneous endovascular fistulas. So this is really exciting and on the horizon. Cable interruption is something that's also advanced in the past. So we actually used to use IVC ligation technique prior to filters. And now you can see how filters have advanced over time, and now they're very retrievable. And we actually can see in the future, and I'll show you here, that we actually have a filter that now is absorbable completely. So they're not permanent at all, and they have also done really well in man clinical trials. So we also have new, this is also on the horizon, but virtual reality and augmented reality in IR. It's in the very early stages, but it's used for training and patient education. And it aids in our procedural planning and intra-procedural guidance. So this is an exciting new field as well, if anybody's interested in you know, AI and virtual reality. So again, artificial intelligence and machine learning in IR is also in the early stages and on the horizon. This can support our clinical decision support systems to overcome staging and scoring systems in interventional oncology. It can improve our diagnosis. It can improve patient selection for our procedures, and it can identify patients that won't respond to our treatment. So this is also very exciting and on the horizon. And this is just an example of AI in interventional radiology. This is in patients with pulmonary embolism. It can actually calculate the RV to LV ratio in the heart and tell us how affected the heart is from the right heart strain is from the pulmonary embolism. So I'm just going to do one quick case in the interest of time. And again, I'm sorry that I started late today. But this is a case of iliocable thrombosis. You can see this patient already has a left internal iliac stent in the vein. And you can see that most the vessel, the vein should look all like this, this kind of white, light white part, or gray, excuse me. And then you see this dark gray area within the stent, and that's clot, acute clot. So you can see this patient had thrombus. And you can actually see on angiography here. So here we're doing an angiographic run. We've accessed the left common iliac vein, or from the left common femoral vein. And you can see that when we inject contrast, it should really go up into the IVC and down the other side. And you can see that it's really thrombosed here and it's not getting to the other side. And you can see you can actually see the stent here on the run, but you can't see any filling of the stent with contrast. And you can see a lot of collateral vessels here, these little veins. And so that's indicative of chronic thrombosis of the iliac and the IVC here. So you can see here, we actually ballooned, and this is our balloon that's now inflated in this, in the confluence of the left internal iliac with the IVC. And you can see after ballooning, there's much improvement in the flow of contrast, meaning that it's less thrombosed here. And then we actually also did thrombolysis, which means that we injected directly into the vessel a thrombolytic, or TPA, which is a blood thinner or clot buster, some call it. And we were able to really improve this patient's flow. I'll do one more case. So this is a case of pulmonary embolism. You can see this is a surgical embolectomy where they cut out the clot, or they do a thoracotomy and actually salvage clot, or take out the clot from there. And we're actually able to get the clot out endovascularly without cutting the patient's chest open, which is really exciting and new, and on the horizon of even there's a lot more we can do with this than we do even now. So you can see here, this is a CT. This is the main pulmonary artery, and you can see that this patient has clot that's extending over the bifurcation. So really a massive PE here, and it's extending into both right and left pulmonary arteries. On angiography, you can see our catheter is here in the right pulmonary artery, and you can see that there's really we'll see after we take out the clot, but usually the arteries are really filling a lot more of the lung here, but there's a blockage from that pulmonary embolism. So here, after we take out the clot, so this is the pre-operative run where you can see again this filling defect of contrast. This is clot here in the pulmonary artery. And then after we take out the clot with suction, you can see that the pulmonary vasculature is filling a lot better here after that. So we've really treated that patient, and we're very successful. And I'll stop here. Yusuf, tell me if I have more time. I have a lot more cases, but I'll stop here in the interest of time. Again, I'm sorry for being late today.
Yeah, I think we're going to move on with Dr. Tummala. But thank you so much, Dr. Goldman, for giving us a proper introduction to the field. So yeah, next we have Dr. Srinivas Tummala, who is with Florida Vascular Specialists. Is a pro when it comes to treating vascular disease, and he has an amazing YouTube channel with a bunch of resources that I will link after. Dr. Tummala, I think you're still muted.
Thank you. Hi, everybody. Hope everybody's doing well. I'm very excited to be here, and thank you for the invitation. One thing I want to do is I'm going to share my screen, and then let's get that up first, and then we'll go from there. Let's see. Okay, can you see that, Yusuf?
Yeah, you're good.
Okay, great. Let me just mute this. So the main thing I want to do is, I'm very excited about this because I think there are a lot of myths related to interventional radiology. And one of the things we're really trying to promote as part of SIR is really education. And I think education starting at the level, at med school, residents, et cetera. When it comes to what I'm going to talk about today, you can see I have a lot of different titles, and I put those there just to show you how important I think education is for all of us, including myself, and how seriously I take this. The YouTube channel really was kind of just came about organically. It was a lot of, physicians who are early career and out in practice were asking me to, send my talks to them and so forth. And these files that I had were really large with a lot of videos. And so I started uploading them to YouTube. And then slowly I started realizing that I had a lot of cardiologists and vascular surgeons and radiologists and med students and so forth who were looking at this stuff. And so then I kind of morphed it into something a little bit more educational. So hopefully today you'll see a little bit of basic stuff. So what I'm going to do is give you kind of just a general overview of peripheral arterial disease. I think it's very important for us to know about this. And then I'm going to show you some various devices and things that we can use. This is not meant to be exhaustive. It's really meant to give you an intro because there's so many things we can talk about. And this field, just like oncology or women's interventions or men's health, et cetera, is very, it's a huge field with so much stuff happening. So with that, these are my disclosures, nothing really pertinent for this talk. So we all know what peripheral arterial disease is, right? We know it's the buildup of atherosclerotic plaque within blood vessels, which cause narrowings and blockages. And because of that, that causes problems. Obviously, this is something that's affecting almost 12 million people in the US and 200 million worldwide. It has a pretty significant growth rate, and that's really because of the explosion of diabetes and CKD. And one thing I want you all to know is that although we don't talk about it that often, is that think about the prevalence of peripheral arterial disease or PAD. It's similar to coronary artery disease, and it's about 1.5 to 2 times more common than stroke. So I want you to think about how common PAD is, but it really tends to be overlooked. If you look at PAD relative to atrial fibrillation and heart failure, it's significantly higher. And so there are more cases of this when you're looking at these really 2 common things. Obviously, when it comes to atherosclerotic disease, it's not isolated to one vascular bed, right? It happens throughout the body, as you all know, and there's a lot of overlap with coronary artery disease and with cerebrovascular disease, which is why these patients tend to have all 3 in various combinations and percentages. And remember that once a patient is diagnosed with peripheral arterial disease, even if it's asymptomatic, that if they are left untreated, they are 6 times more likely to die from a cardiovascular event, which really means heart attack or stroke. That is why risk factor modification, whether you're a primary care physician, a vascular doctor, an interventionalist, et cetera, is so important because, obviously diet, smoking, blood pressure, glucose control, lipid management, making sure that they're taking statins and so on and so forth are very important. And that's why medical management becomes very important. So even if you end up going into interventional radiology, this is really where the field is blossoming and kind of exploding and going towards. And so we all have to understand a lot of these things while we treat these patients. Remember that when you look at CLI, which is critical limb ischemia or chronic limb threatening ischemia, as they call it sometimes, CLTI, when you compare it to all the different types of cancers, there's only 6 that have a higher 5-year mortality rate. So I want you to think about that. We talk about cancer, we talk about oncology, we talk about MIs and stroke and so forth. There's only 6 cancers which have a higher 5-year mortality rate than CLI. So once somebody is diagnosed with the most severe form of peripheral arterial disease, known as critical limb ischemia, look at their 5-year mortality rate. It's terrible. And so this is something that, again, is kind of in the background. A lot of people aren't talking about it, but it's gaining a lot of traction now. So how do you classify peripheral arterial disease patients? Well, there's many ways. You can have, we always think of the classic, they walk, they have pain with walking, they rest typically 10 minutes, and then the pain goes away, whether that's in the buttock, the thigh, the calf, et cetera. So it's reproducible pain with exercise. What you have to remember is really only about 15% present with classic claudication. The majority of patients are asymptomatic. That means that atherosclerotic plaque was seen on other imaging studies, whether it was ultrasound, CT, etc., and it just was picked up incidentally. A third of patients present with atypical leg pain. So that means most of the patients coming into a primary care physician's office, a podiatry office, etc., they're coming in with pain that just doesn't make sense. And so that's where the workup becomes the most important. Critical limb ischemia, or CLI, CLTI, obviously is about 2%. When you look at classifications or categories, there's multiple ways to look at this. This is the most common when you're looking at acute limb ischemia. This is somebody that presents with basically a heart attack of the leg, right? So you think of a heart attack, you get a blockage of a vessel in the heart, it's an MI, it's a heart attack. You get a blockage in an artery going to the brain, whether it's in the neck or within the brain, then you get what? You get a brain attack, which is a stroke. You get an acute blockage in a major artery in the leg, you get a leg attack. And in this case, it could be acute or acute limb ischemia. And this is how they categorize it. This is just to kind of give you an overview of what that means. When it comes to non-acute leg pain, that means the average person that just says, oh, doc, I got some leg pain, I'm not sure what it is, or I'm walking and I notice that my calf, or I'm getting thigh pain when I walk a certain distance, but it goes away when I rest. This is really the categories, or the Rutherford classification. This is originally called Rutherford-Becker classification. Gary Becker is an interventional radiologist, was my mentor when I trained as a fellow years ago. And, now for ease, we all kind of refer to this as the Rutherford classification. And so what you have to realize is that when somebody is considered Rutherford class 4, 5, or 6, those are the CLI categories. That's the most severe form of peripheral arterial disease, typically manifested by rest pain, non-healing ulcers, and gangrene. And remember that there are objective measures on how to determine if somebody has CLI. So you have physical exam and you have diagnostic testing that can help you. Once somebody is diagnosed with this more severe, the kind of the most severe form of PAD known as CLI, you can see what the 1-year outcomes are. We talked about how it is relative to cancer. Well, look at this. At 1 year, you have 50% are alive with 2 limbs, but a quarter have had an amputation and a quarter of them have died of some type of cardiovascular event, MI or stroke. So you can see that the outcomes at 1 year and even beyond are terrible once somebody is diagnosed with this. And so you have to take this very seriously when patients come in. And the reason for this is really the explosion of diabetes and CKD, and the fact that atherosclerotic disease affects the entire vascular tree throughout the body: brain, heart, mesentery, renals, legs, arms, etc. It can be as simple as this: small, tiny ulcers, small petechial hemorrhages on the toes and so forth, or it can be something more severe like this. These are patients that I've treated over the years to show you kind of on the left what it looked like and on the right after therapy. And so you can see that we can treat really a huge spectrum of patients. When it comes to diagnostic testing, these are all the things that you've learned, in med school on different rotations, pulse volume recording, segmental pressures, ABI, TBI, all these fancy names you hear, all the way to CTA and MRA. And I will tell you that the majority of vascular specialists today really rely on the ABI and the TBI, as well as a duplex ultrasound, as the first screening test for a lot, and PVRs, of course, of a lot of things we do. So what about access options? This is a slide that was lent to me, but you can see that now we not only are able to access these blood vessels, which are basically like highways, in the wrist, the radial artery, whether it's the groin, the common femoral artery, or the proximal SFA, the thigh. We can access vessels around the ankle, the tibial vessels, the dorsalis pedis. We can even access digital arteries. So you can see we have a lot of access options today. And you can see this is a friend of mine, Art Lee, who sent me this. And you can see that we've accessed a common plantar artery or a lateral plantar, and we've accessed the dorsalis pedis artery. So we have options of accessing many different parts of the body to get through blockages. We have a whole bunch of, CTO means chronic total occlusion. So it's a blockage in an artery that's chronic. And we have a whole bunch of techniques now that are well described, not only in the coronary literature, but in the IR literature as well, in terms of how to get through blockages, whether it's from above, from below, both sides, etc. And these are really proven techniques. And this is what a lot of these look like. You can see here, I put 4 videos together just to show you what the different type of recanalization techniques look like when you're using just very simple devices like a catheter and a guide wire. And you can see here, this is an occluded superficial femoral artery, or SFA. And I'm showing different techniques to our fellows and early career physicians and cardiologists and so forth in terms of how to get through these blockages to result in a successful revascularization. We also have various CTO crossing devices. These are all the devices that are available for getting through blockages in the arteries in the legs and the arm, mainly in the legs, to help us in terms of doing things. And I thought I would show you 2 examples. So here's one that shows you really that it is a device with a curved needle, which you can actually orient whichever direction you want. And if you look at that video on the lower left there, you can see that this person is snaking through this blockages to really get through and through access with the guide wire. Because remember, if we can't get through these blockages, then we can't have a successful revascularization, then we can't prevent amputation or treat their symptoms. And then ultimately we can't prevent them from having something more serious later on. Here's another device. Again, another one. This one is a catheter, which has a beveled needle at the end. And that beveled needle lets us kind of cork through an occlusion and get through really tough segments of a chronic total occlusion, whether it's at the beginning, in the middle, or at the end. So it's another device that lets us get through a lot of these blockages. We also have various devices that once we've crossed a CTO or a blockage, that we can now clean out what's inside the blood vessel, whether that's soft atherosclerotic plaque, calcified plaque, thrombus, or a combination thereof. You can see that we have a lot of options in terms of, shaving off this plaque and getting through it. This is one of them by Boston Sci. It's called the jet stream. And what this does, it acts like a drill bit. So this is called rotational atherectomy. So it's shaving the plaque. It's got an aspiration port. It uses the physics principle, the Bernoulli principle, to basically aspirate and remove this plaque from within the body so it doesn't go downstream and cause other problems. We have devices that now, I'm sure all of you have heard of lithotripsy when it comes to stones and urology. Well, we now have a device that lets us perform lithotripsy within a blood vessel. And you can see here that these sonic pressure waves are basically causing microfractures within the calcified plaque that's along the lining, the intima, within the blood vessel wall called the media. And then that softens it so that we can really expand the blood vessel and get good luminal gain, meaning an optimized tube to allow blood flow to get through. So this allows us to then do other things to improve the blood flow. We also have other devices. This is now, we're in the realm of orbital atherectomy. You can see here that this device by CSI rotates in an orbit, kind of like around like a satellite around a planet. And it does 2 things. It basically shaves plaque and sands it, as they say. They call it differential sanding. But it also results in pulsatile forces as it kind of bangs up against the wall in terms of causing microfractures within the medial calcification, which then again, the particles that it creates are really smaller than a red blood cell. So the idea here is that because they're so small, they wash out the capillaries, they don't get plugged in the arterioles or the distal vascular beds of the foot or the toes. And you're able to, again, increase the size of the lumen so that you can improve blood flow, whether it's with angioplasty, drug-coated balloons, drug-eluting stents, non-drug-eluting stents, and so forth. So let's look at a case. Here's a classic patient that came to me who had really class 3 Rutherford claudication. So that means that they were basically had the most severe form of claudication, where when they walked 25 feet, they had excruciating calf pain. And as a result, this patient is a construction worker and was not able to work and function properly and was really about to apply for disability. He came to me and, we had put him on medical management for about 3 months, as well as a supervised exercise program, which he failed, meaning that he didn't improve, he didn't get better. And so then we used one of those devices. I think you can see this is the popliteal artery for the most part, right? It's across the knee joint. We've got a couple of areas of really dense coral reef atherosclerotic plaque. You can see that toothpaste white stuff in the middle of the blood vessel on the right image that I've circled to show you what plaque can look like and why it's basically plumbing, right? So his ABI, or ankle brachial index, was abnormal at 0.6. And then what did we do? We basically shaved down that plaque as best we could. And then we were able to do other therapies to improve the blood flow. And then his symptoms basically resolved. So really by the next day, within 24 hours, 48 hours at the latest, they notice a significant difference in terms of walking ability. We also have the ability now to really treat below the ankle blood vessels. So this is called pedal artery revascularization. I wrote an article for Seminars in Vascular Surgery, really reviewing this because they invited me to kind of review the data and give them all the techniques that are available now. And so that's been published and is available if you ever want to see it. But you can see here, this is called the pedal plantar loop. There's 3 anastomoses below the ankle. This is the most common. This is the one you'll see on social media with all the great cases, or the one that they do live cases on. It's basically a continuation of the dorsalis pedis artery, which gives a branch called the deep perforating artery, which then joins into the lateral plantar artery and then goes back to the posterior tibial. So you have a loop that's connecting the anterior and posterior circulation of the foot. So it's the major outflow, or the last outflow of the foot. You need this for this foot, so to speak, or leg to survive. And you can see now on the right, I have a catheter and I have a guide wire, and that's another whole discussion, right? What types of catheters and guide wires? And you can see I am navigating this diseased pedal plantar loop that this patient has in this case. So let's end here with a couple of quick cases so that you kind of understand what I'm talking about. Here's a patient who has all the classic hallmarks of chronic ischemia, right? They've got hairless, shiny skin, thickened nails. They've got a deep ulceration or wound really down to the tendons on the lateral aspect of the foot. You can see all the skin discoloration, and you can see this patient even has mild edema. You don't want to mistake this for edema related to a venous problem. This is a patient who has profound rest pain. That means they have pain when they're just resting, when their foot is up, on a chair or on a couch, when they're sleeping at night. So because it hurts so much, they keep it in a dependent position, which is why they end up getting a little bit of edema. This is classic arterial ischemia. This has nothing to do with a venous problem like a DVT. So he was told that he has no options and they should basically do a below the knee amputation. We did the testing, we brought him in, we did an angiogram. I'm trying to show you that the popliteal artery at the knee joint is occluded, or just below it is occluded. There are really no great vessels below the knee joint or in the ankle that we can see. We don't know what's going on below the ankle because we don't have enough blood flow to really tell us if anything is opened or shut down. So as you can see here, we decided to use multiple access points. I got access from above, I got access from below. Then we saw that we were not in the same channel within this occluded blood vessel. So we used various techniques to allow us to get through and through access. You can see on that final video on the right, I got the guide wire from below to get into the catheter from above. So now I have kind of like, it's like floss, so to speak. So there's a guide wire entering the foot, going through this blocked channel and coming out the patient's groin. So I have through and through access. In this case, I did orbital atherectomy. As you can see here, we're using orbital atherectomy to shave the plaque. You can see I have a catheter or a sheath in the dorsalis pedis artery. And I open that sheath to not only let the debris clear out, but to also, it tells me when there's blood flow has been kind of returned to this blocked blood vessel. And then ultimately we do some other maneuvers to improve the blood flow, in this case, angioplasty. And you can see here now we have a nice 2-vessel runoff to the foot, including the anterior tibial artery and the perineal artery in this case, with some blood flow filling a posterior tibial artery. And the arrow I'm showing you I'm showing you kind of a pre and post. And I think you can see the difference in blood flow. So there were a lot of blood vessels below the ankle, which were open, but just weren't filling well. So we couldn't see them. And that red arrow is showing you a wound, and the wound blush, as it's called, because that's a good prognostic indicator that this patient is going to heal and do well. And over the course of about 1 year, you can see we got significant healing with really good wound care and skin grafts and so forth. Last case, we have another patient, diabetic, who had started off with a tiny ulcer on the great toe. Him and his doctor ignored it. And then by the time I saw him, he has the black areas are gangrene. You can see he's got profound ischemia with erythema and dependent rubor. So he had also elevation pallor, right? You elevate the leg for about 2 minutes and you'll notice that these red areas slowly start becoming a little bit paler or whiter. And so he has all the classic hallmarks of chronic ischemia, right? We've got dependent rubor, elevation pallor, we've got erythema, and we've got gangrene. He also had underlying infection, which we treated with antibiotics. We found that the reason everybody was ignoring him is they kept saying, well, your dorsalis pedis artery is palpable. The reason it was palpable is because the proximal part of the DP was open and the rest of it is occluded. So everybody was feeling kind of in the usual place closer to the ankle and saying, oh, you have a pulse, when in reality, the rest of it was basically blocked. So I basically opened it up, did again something to shave off plaque, and we were all ultimately with good wound care get healing. So we basically prevented a 4-foot amputation and converted him to a distal or mid great toe amputation. Big difference in terms of quality of life, as you can imagine. So I just wanted to say in summary, peripheral arterial disease is very important. Medical management is key today. Remember that these patients who are diagnosed with PAD have a really high mortality rate when it comes to cardiovascular events such as MI and stroke. And obviously, we want to always try to prevent amputations and so forth.
Yusuf, I'm an interventional radiologist at the University of Chicago. Dr. Tummala just gave a fantastic presentation on arterial disease. I will be speaking with you all about venous interventions, which is, a huge sort of genre within interventional radiology. And similarly, other specialties may sort of do some of these procedures, but in general, interventional radiologists sort of do a lot of these. So we're going to start out by defining what venous disease and interventions are. And then, essentially, I want to just spend the rest of this time just showing you guys sort of the vast variety of what we do and how we are able to help patients with, multiple different pathologies. So I would argue that venous interventions are probably one of the most rapidly growing areas of interventional radiology, whereas arterial sort of the treatment of arterial disease or peripheral arterial disease has been one of the sort of cornerstones of IR. Venous stuff has really started to emerge over the last 5-10 years. And really, when we talk about venous interventions, we're talking about multiple treatments to treat whether it's venous thromboembolism, but there's also a variety of other venous pathologies we'll try to touch on as well. So, in general, the way I try to think about this is, when we talk about venous disease, we can sort of divide it into the superficial veins and the deep veins. For the most part, I'll probably talk about sort of deep venous disease. But it's important to know that, superficial venous disease is sort of what you think of when you think of patients who have, garden variety, varicose veins, GSV reflux, things like that. But then when you sort of get into this umbrella of deep venous disease, there's a ton of sort of things that we do. And a big component of that is venous thromboembolism, or VTE. And VTE is really just a spectrum of disease that starts with DVT and essentially extends all the way to PE, which is sort of the most severe manifestation of that. I'm going to sort of try to divide up the interventions that we'll talk about into sort of lower extremity, abdomen and pelvis, and then finish with upper extremity and chest. And so when we talk about patients who present with venous disease of the lower extremities, these are the patients who are often presenting with lower extremity swelling, pain, cramping, heaviness, discoloration, ulceration. And really the preferred imaging to sort of assess a patient for venous disease in the lower extremities, and specifically DVT, is to get an ultrasound. And then if you are concerned about proximal extension of DVT into the abdomen, specifically into the iliac or IVC, then we want to get either a CT venogram or MR venogram. And in our institution, it's pretty much CT venogram. Some of the most severe diseases that we'll talk about, the spectrum of diseases we'll talk about include acute iliofemoral DVT, which is, again, a cornerstone of treatment in IR. May-Turner syndrome, which is a very classic disease, for boards and things like that, and something that we not uncommonly see. We'll also talk about chronic iliofemoral DVT, which is very different than acute DVT. And then superficial venous disease, as I mentioned. I won't really talk too much about this, but just know that this is part of the spectrum of patients who present with some of those symptoms. When we talk about treatments for DVT or the diseases that I've mentioned, acute iliofemoral DVT, we're going to be talking about catheter-directed thrombolysis, which is also known as CDT, or mechanical thrombectomy. May-Thurner syndrome is going to be treated with thrombectomy or thrombolysis with stenting. And chronic DVT is going to be treated more with recanalization with angioplasty and stenting. And superficial venous disease is going to be GSV ablations, therapy, phlebectomy, things like that. So now focusing on DVT. DVT is probably, one of the most common things that we're, consulted about in interventional radiology. It's a major public health problem. It's very common, 80 to 80 cases per 100,000 people. The incidence of total VT, both DVT and PE, is nearly 1 million patients, like 900,000 a year. So it's a huge number of patients that are affected. And really what we care about the most with DVT is that it can lead to a PE and be potentially fatal. However, that's really not the main reason we are intervening when we treat DVT. The main reason we actually treat DVT is actually, if DVT sticks around, it can cause something known as post-thrombotic syndrome, which is basically a constellation of symptoms, sort of a laundry list of symptoms that I mentioned earlier, that cause valvular damage and lead to venous hypertension. And if that, if you develop post-thrombotic syndrome, which about 50% of patients with DVT, especially with more proximal DVT, develop, that causes major morbidity. And so while it seems like we're doing a lot of interventions for DVT to prevent, to potentially prevent PE, it's actually more that we're trying to prevent the morbidity associated with post-thrombotic syndrome. And the way that we treat that, again, in IR is with catheter-directed thrombolysis and or thrombectomy. And again, this is sort of a medical student level talk, so I'm not going to get into the data, but it's really important, if you have the time to sort of look up some of these studies and try to understand, the basis for why we're doing some of these procedures. And the two big studies that we often cite to sort of support what we do is these studies are called CAVENT or CAVENT and ATTRACT. And these are multi-center randomized controlled trials, comparing patients with and without thrombolysis. While you'll see that some of the data is conflicting, the bottom line takeaways, and which is relatively consistent with both studies, is that we treat patients really that are acutely symptomatic, who have basically a large thrombus burden if they have a clot extending into the iliofemoral system, which is basically the common femoral vein or above, and younger patients, and generally patients younger than 65 who will derive benefit. Those are the people who are sort of ideally who are targeting, and we'll treat them with like as I mentioned, CDT or thrombectomy. So here's the first example. This is probably one of my first cases out of training. As a patient had a IVC filter placement 3 months prior for orthopedic spinal surgery. He had a right femoral DVT and a paraspinal hematoma. So he had an IVC filter. He came back for filter retrieval. And interestingly enough, his ultrasound was negative for DVT. But then when we went to do this venogram, you could see that red arrows show that there's contrast missing all the way up, extending into the filter. And that's really essentially a complete acute thrombotic occlusion of the IVC. So, and you can see here's an injection above the filter. The IVC is widely patent. This is what it should look like. So, the diagnosis we made here was a filter-related thrombosis of the IVC, and we chose to do catheter-directed thrombolysis for this patient. So we started an infusion with TPA at 1 milligram per hour. And you can see here, not really a terribly sort of difficult procedure to do, and with not many findings, but you can see here, the yellow arrows show the marker bands of the infusion catheters. And what essentially will happen is these infusion catheters will slowly drip TPA throughout the sort of extent of the thrombus with lytic infusion. And the reason we do this slowly is because if you give it sort of high doses at a quick rate, you could potentially cause bleeding complications. So we do this, and the patient comes back, stays in the ICU for 24 hours, comes back the next day, and you can see here, without any other intervention, we inject, and the IVC is completely patent. And so this therapy is tremendously effective for the treatment of large burden of DVT. And then we were able to safely remove the filter. So, that was sort of the conventional way that we've treated DVT or any clot really. But we have evolved with newer devices to sort of treat DVT sort of what we call in a single session. So instead of admitting them to the ICU, we can also sort of go in and sort of mechanically debulk the thrombus and remove it. And this has really shifted the paradigm of how we manage a lot of clot today. So while we still do CDT, we're doing a lot more mechanical thrombectomy because we believe that there's probably a lower risk of bleeding because we're not giving TPA, and it's a little bit more comfortable on the patient in that they don't have to go to the ICU. So here's another example. So, of a patient who essentially presented with abdominal pain for 2 weeks that had worsened and essentially had the sort of the same disease, extensive IVC thrombosis. We attempted to treat this patient actually with CDT first. And again, you can see here, just by the way that this clot looks, I think with the first case, you kind of didn't see all these extensive collateral vessels that you see here on the image on the left. So this tells us that this probably thrombosis is not a very super acute, and that there's probably some chronicity to this clot. And that's important because, when we put these infusion catheters, if you can see all the way on the right image here, this patient came back after 24 hours and you didn't actually see much recanalization. And a lot of that is because the acute thrombus, there's not a lot of acute thrombus that's sensitive to TPA, whereas more subacute and chronic thrombus is not as sensitive. So at this point, we chose to do something or large bore mechanical thrombectomy with this device you can see here, which essentially is sort of like a large vacuum cleaner. And we came from below and we basically sucked out all the clot. And you can see here, this was the first image showing pre, the second image showing sort of post thrombolysis with not much improvement, but then this is after mechanical thrombectomy. You can see here that we've really restored flow here. And again, we were able to do this sort of in a single session without admitting the patient to ICU for any additional TPA. So the next thing we'll talk about is May-Thurner syndrome, which is a compression of the left iliac vein by the overlying right common iliac artery. This is a very common cause of iliofemoral DVT. This is sort of a cartoon schematic of what this looks like. And this is what it looks like on CT. You can see here, there's a left iliac vein, which is sort of smushed as it passes under the right iliac artery. Everybody has a degree of this, but for some patients, this is more pathologic. It can cause spurring and essentially occlusion and DVT. And so you can see here, this is a patient who actually has May-Thurner compression without actually any DVT. You can see the yellow arrow showing the compression there, the yellow dashed arrow showing a paraspinal or a lumbar collateral, and then the arrow ahead here showing sort of cross pelvic collateral. So this patient has sort of hemodynamically significant compression of their left iliac vein. And again, we only treat these patients when they're symptomatic. And this is what it looks like post-stenting. You can see all those collaterals are gone and we have inline flow. And this is a CT of what that stent looks like. Now it's sort of, you can see the vein lumen architecture is restored here. It's a big sort of round circle as opposed to it being smushed by the artery. When we talk about chronic DVT, this is a much more challenging disease or entity to treat. This is sort of when the acute DVT wasn't necessarily recognized or treated, and that DVT sticks around. And what happens is chronic DVT is sort of a misnomer. It's not really DVT anymore. It sort of turns into scar. It causes luminal atresia or sort of narrowing of the vessel. And so a lot of times the vessel essentially disappears. And this is much more challenging because you're sort of searching for a needle in a haystack in terms of you're trying to find where this occlusion is, and you're trying to basically get a wire through that to reconstruct that vessel with angioplasty or stenting. So we're not really doing thrombolysis or thrombectomy for chronic DVT. It's actually more like probably like Dr. Tummala showed in his arterial lecture, like more of a like a chronic arterial CTO or chronic occlusion where you're trying to get through it and open it back up. And you can see here on the CT, it's the coronal CT, the yellow arrow sort of shows what the vein should look like. And then that red arrow sort of shows that the vessel there is sort of atretic or narrowed. And this is what oftentimes the venogram looks like. You inject and it sort of just goes nowhere. There's no sort of normal pathway for the vein to drain. And oftentimes you'll see a ton of sort of venous collaterals. And so you can see here, we've already recanalized this occlusion. There's a wire across that. And so what we're going to do now is we're going to basically do angioplasty to sort of open up the vessel. This is what it looks like post angioplasty. You can still see there's sort of a fair amount of narrowing, And then we're going to stent it to sort of complete the reconstruction. You can sort of see here now we've restored inline flow. Again, we're often doing this treatment for post-thrombotic syndrome. We're not doing this to treat or prevent a PE. We're trying to help relieve a patient who has symptoms of leg swelling, edema, pain. Moving on to like abdominal pelvic symptoms related to venous disease, patients can present with sort of a lot of non-specific symptoms, but pelvic pain, bloating, pain with intercourse, abdominal labial varices. And the disease conditions that we're often thinking of when patients present with this includes May-Thurner syndrome, pelvic congestion, which is also sort of known as gonadal vein reflux, as well as nutcracker syndrome. And pelvic congestion is probably the main thing that we sort of think of or sort of talk about when we consider, sort of pelvic venous disease. And these are basically dilated pelvic and or labial varices. And the pathology presents on imaging with essentially dilated ovarian veins that are refluxing. And this could be either unilateral or bilateral. And really what we're trying to do here is we're trying to go in and embolize those vessels to sort of redirect the blood flow. This kind of like varicose veins of the abdomen. You're basically trying to get rid of the pathologic vessels to redirect blood flow to sort of more normal vessels that can sort of more efficiently drain the blood. So this is a patient with 25 with chronic pelvic pain. She's 25-year-old female, which is sort of a classic presentation, sort of young females. You can see here the yellow arrow shows a dilated left ovarian vein. If you're looking on CT, oftentimes you shouldn't be able to even find or see the ovarian vein. So the fact that you can sort of easily recognize it tells you that it's probably pathologic. This is on the coronal. You can see that it's again abnormally dilated and again relatively easy to see and find. So here's a left renal venogram, and you can see here the contrast is sort of refluxing into the dilated left ovarian vein. So again, these are typically not very challenging procedures to sort of get in and catheterize the dilated ovarian vein. You can see here now, you can see this like sort of ugly nest of pelvic varices, and this is sort of compatible with pelvic congestion syndrome. This is sort of what's happening is this blood is sort of pooling and sort of resulting in the symptoms that we talked about. And so what do? We do embolization of this. So often what I'll do is inject, I'll often do sclerotherapy where we inject foam, and then we'll sort of top it off with coils or in this case, we use plugs. And you can see here that we've essentially embolized that. Nutcracker syndrome, I've only probably treated like 2 or 3 patients for this. It's incredibly rare, but what it is it's compression of the left renal vein by the SMA and aorta. It presents with flank pain and or hematuria. So that's really important because what it's doing is causing sort of pressurization of the left kidney or renal sort of drainage. And so those patients will essentially present with sort of renal symptoms like flank pain or hematuria. And this can often be treated with a renal vein stent. Sometimes it's also treated or dealt with a renal vein transposition by surgeons. But oftentimes I've stented this. Again, this is very rare. And then so moving on to upper extremity symptoms, this is sort of manifested as facial swelling, arm swelling, pain, discoloration. So very similar to lower extremity symptoms, but applied to the chest or arms. And so the disease states really sort of that are most commonly talked about or sort of discussed are Paget-Schroeder syndrome, as well as SVC syndrome. And what Paget-Schroeder really is it's venous thoracic outlet syndrome. And this is commonly seen in young athletes caused by cervical or first rib compression. It's exacerbated by abduction. So as they raise their arms, so you'll see it with swimmers, baseball players, golfers, because they're commonly sort of, abducting their arm. And so the main thing to know is that the treatment really is actually surgical. It's to remove the rib. But very often you need to do thrombectomy or thrombolysis prior to surgery due to the DVT. So you got to get rid of the DVT, open the vessel, and then do the surgery. And we really don't do stenting because there's a mechanical compression by the rib. But you can consider stenting after the procedure. And oftentimes patients may come after the surgery as well with sort of needing additional intervention. So here's a thrombotic occlusion of the left axillary and subclavian veins. This is sort of what I'm showing you. You can see collateral veins there. Sort of you can see that they go up and then they sort of reconstitute the brachiocephalic vein centrally. So what do we do? For this patient again, we did a overnight catheter-directed thrombolysis, and oftentimes we do this in conjunction with vascular surgery or thoracic surgery, where we'll do this thrombolysis or thrombectomy, and then admit them, and then they'll go to surgery the next day, because if they don't sort of operate relatively soon, the mechanical compression is still there, and they'll rethrombose. So here is what it looks like post thrombolysis. Again, you can sort of see that normal inline flow has been restored. You still see sort of that narrowing of the subclavian, and so this patient's going to go to surgery and get that rib out. Finally, I'll sort of conclude talking about pulmonary embolism. This, PE in general could be its own talk. There's entire meetings dedicated to PE, so I won't go into a lot of detail here, but really it's important to know that PE is sort of, it's the real deal, obviously, in the sense that this is a potentially fatal condition. It's the worst sequela on the VTE spectrum. This is really what we're mainly concerned about when we see patients with DVT. This is why we're treating them aggressively with anticoagulation and things like that. But there's been an explosion of interest in treating this endovascularly because of the sort of emergence of devices that are available to us, as well as sort of CDT, which is still commonly used. PE is really divided into 3 categories: low risk, intermediate risk, and even intermediate risk is sort of divided into its own subcategories, and high risk. And really what's important to know is that it's divided into these categories based on clinical factors. It's not by how much clot you have, it's by how you're doing clinically. And when I say clinically, I mean, do you have right heart strain? Are you hypotensive? Are you short of breath? What's your age? Things like that, comorbidities. Again, trials to really know and understand include Seattle 2, Ultima, and the Perfect registry. These are basically the fundamental studies that sort of established the efficacy of CDT, specifically catheteric thrombolysis for PE, and they provide us the rationale for treating PE to reduce thrombus burden, to relieve right heart strain sort of in a quicker fashion to improve hemodynamics. So here's just an example. This is a 53-year-old female with submassive PE. As I mentioned, we've really shifted from a lot of patients, especially who are sort of acutely ill and acutely sick, from doing CDT to doing thrombectomy now. So this is sort of an example of that. So you can see here, this is a patient with an acute PE, a large right main pulmonary artery thrombus, as you can see here. And again, we're not intervening these patients unless they're acutely symptomatic and with some element of right heart strain or hypotension. And you can see here, this is, again, the coronal CT, and this is that clot again. And you can see here on the pulmonary angiogram, there's that clot as well, sort of very nice sort of correlating there. And so this is one of the sort of newer devices that has emerged. It's a 24 French device that basically can go in and suck that clot out. And you can see here, just after a few passes, that the clot has been sort of aspirated and relieved. And so this patient actually got a follow-up CT. This is not necessary, but sometimes it's done. And you can see here, all that clot is completely gone. And so in conclusion, there's a wide range of pathologies. We just gave you sort of a whirlwind tour of the things that encompass venous disease. And we really only talked about what I consider probably the most exciting type of cases, but there's a bunch of other things that are out there. And I think the future is only increasing and expanding for these types of procedures. So with that, I thank you for your time and attention, and I'm happy to answer any questions, or for the sake of time, happy to move on as well. Looks like Andrew Tate has signed off, so probably not many more questions.
Thank you, Dr. Ahmed. It was a good job of covering kind of the whole broad spectrum of venous interventions. Next up, we have Dr. Divya Kumari, who's also from the University of Chicago.
I'm having difficulty sharing my screen.
Do you try to click on the green button?
Yeah,
And
my
it's-
host.
It says you are.
Okay, you know what? I see it now. Okay, sorry about that.
You're good.
All right. All right. Thanks everyone for having me here today. Today I'll be talking about portal interventions that we do in IR. Portal interventions are one of my favorite procedures in IR. So I'm really excited to talk about this. I'm from the University of Chicago. So first I'm going to talk about the anatomy of the portal vein, and then I'll go into details of portal hypertension and discuss the two main procedures that we do in IR to treat portal hypertension. We'll talk about TIPS, which reduce portal hypertension, as well as BRTO, which treats the symptoms related to portal hypertension. First discussing portal vein. Portal vein is the main blood supply to liver, provides 75% of the blood to liver. It's composed of drainage of three main vessels, the SMV and the IMV, drain the bowel, as well as the splenic drainage from the splenic vein. When these three vessels converge, it becomes the main portal vein. And then when the main portal vein enters the liver, it splits into the right and left portal vein and delivers blood to the liver for further processing. So normal portal venous pressure is 5 to 10 milliliters per mercury. When you have elevated portal pressures, this is due to increased vascular resistance. There's various causes of portal hypertension that can be categorized by pre-sinusoidal or pre-hepatic, and that would be portal vein thrombosis. You can have sinusoidal or intrahepatic causes, and that's one of the main causes of portal hypertension would be cirrhosis. Chronic liver disease causes fibrosis and distortion of the parenchyma, which causes elevated resistance to the portal venous flow, and then post-sinusoidal, which would be Budd-Chiari syndrome. So portal hypertension is diagnosed by having a pressure of greater than 10 milliliters per mercury, but also having a portal and systemic venous gradient of greater than 5. Portal hypertension can result in can really affect daily life of living. It can cause ascites, hepatorenal syndrome, hydrothorax, and the formation of collaterals and varices. When the portal pressure is greater than 12 milliliters per mercury, these varices have a tendency to bleed, and when they rupture, it can cause life-threatening hemorrhage. So going into more detail about variceal bleeding, varices are present in up to 75% of the cirrhotics, and at one-third of them will rupture at some point. Has a really high mortality rate, 25 to 50% after the first bleeding episode. And for a few days after, the rebleeding risk remains pretty high, and it tends to level off after 6 weeks. When these patients present with variceal bleeding, the first line of treatment is endoscopy. Interventional GI can go in and scope. They can diagnose the varices, identify which ones are bleeding, and grade the varices. And at the same time, they can also band and sclerose varices. If there's failed endoscopy, if they're unable to successfully stop the bleeding, or and they're afraid of a high rebleed rate, that's where we can come in. So to briefly go over the treatment options for variceal bleeding, medical management includes sclero and banding, and then medical treatment also includes octreotide, beta blockers, supportive management. Surgical management for variceal bleeding has a high morbidity and mortality, and often these patients aren't great surgical candidates, but there's options of creating surgical creation of a shunt or esophageal transection. Transplant would be, the most ideal way of treating this. But mostly the treatment option for us of TIPS and BRTO is very minimally invasive and a lot safer for this group of patients. So to get into it, to do a TIPS, unlike endoscopy, you're actually treating the underlying portal hypertension. TIPS stands for transjugular intrahepatic portosystemic shunt. What you're doing is basically bypassing, the fibrosis in the liver, causing the intravascular resistance by creating a low resistance conduit between the portal vein and hepatic vein through the liver parenchyma, and putting a stent there to, create that bypass. By doing this, you're reducing the portal hypertension and then reducing the complications related to portal hypertension. To evaluate whether a patient would be a good candidate for this procedure, what we mostly look at is the MEL score. And this is calculated using the bilirubin creatinine INR and dialysis, and it helps predict the outcomes in patients being considered for TIPS. A MEL score of greater than 18 predicts early mortality after TIPS placement. So the indications for TIPS, primarily secondary prevention of variceal bleeding and refractory acutely bleeding varices unable to be treated by endoscopy. We can also do TIPS to reduce refractory ascites, to treat Chiari syndrome and hepatorenal syndrome. There are contraindications to doing this procedure. When you do a TIPS, you increase the preload to the heart. So it can cause right-sided heart failure or worsen right-sided heart failure after the procedure. People that have chronic disabling hepatic encephalopathy, because you're creating this bypass, a lot of the metabolites aren't being processed by the liver, and this can cause new encephalopathy or even worsening, and it can have really bad consequences. The worst would be the patient presenting in a comatose state. The other thing is people that have severe progressive lip failures, the main portal vein is the primary supply to the liver. If you shunt part of it away, it could worsen liver disease acutely. So when we do a TIPS, we use fluoroscopy mostly, and this is kind of a live X-ray machine as well as ultrasound guidance. This is usually done with general anesthesia. You want to access the right internal jugular vein using ultrasound guidance. You advance a long sheath across the right heart into the IVC. Then you use a catheter to preferably get into the right hepatic vein. You can wedge the catheter and then do a portovenogram, most commonly done with CO2. And this retrograde fills the portal branches. And so, you know, when you do a TIPS, you're basically working with a 1D image, but it does help guide your needle into the portal vein. Using a TIPS set, which it consists of a 16-gauge metal cannula, a 7 French sheath, as well as a long needle and a catheter surrounding the needle. You want to, if you're in the right hepatic vein, you want to twist the system anteriorly to try to access the right portal vein. And so basically you're advancing the needle through the wall of the hepatic vein and puncturing the portal vein through the liver parenchyma. Once you enter the portal vein, which is actually quite challenging, you want to do a portal venogram. This will kind of lay out the splenoportal anatomy as well as help you evaluate the varices that are present. Once you gain access in the portal tract, you want to dilate the parenchymal tract, and we usually start off with a smaller balloon catheter, usually 8 millimeters, but also can, use larger ones depending on the gradient. And then we deploy a very specifically designed tip stent to, maintain that channel between the hepatic vein and portal vein. This tip stent is very unique in the sense that the interparenchymal part is covered and the portal aspect of the stent is uncovered within the portal vein. So it has really been a game changer in improving patency of the tips after this procedure. Some of the complications that may happen with the tips is displacement of the stent, shunt thrombosis. If you puncture outside the liver, you can get hemoperitoneum, which can be life-threatening, cardiac failure, liver ischemia, portal vein thrombosis, and worsening of encephalopathy. So, nowadays we've been using the ICE catheter, which is an intracardiac echo catheter, to do more precise puncturing into the portal vein. And it's basically a catheter that you can put in the IVC at the level of the portal vein. And using this catheter, you can guide your needle from the middle or whatever hepatic vein is most accessible into the portal vein. So it's a lot safer, and you can do more challenging procedures. If the right portal vein has some thrombus, you can still identify it under ultrasound and target it. So the whole goal of doing a TIPS is to reduce that gradient, the portosystemic gradient. Ideally, you want it to be less than 12, and this should decompress the varices and reduce ascites. And then at the same time, you want to make sure that it's greater than 4 to reduce the chance of encephalopathy. When you place the shunt, you do the measurements of the pressure, and if the gradient isn't as low as you'd like to be, you can keep dilating the stent to reach the goal pressure gradient. So the stent is designed to be expanded to 10 millimeters per mercury to accommodate a lower systemic gradient. If there is a need to shut down the shunt, you can access it and also narrow it or close it down via this access. So TIPS has a pretty low mortality rate, and that's usually because there's careful patient selection done for this procedure. It's less than 1%. The rate of accelerated hepatic failure is only 1 to 5%. Worsening encephalopathy happens 20 to 30% of the patients. Usually you can treat this medically. And then the other things to look out for is bleeding, infection, and then late shunt stenosis. Usually after the placement of a TIPS, you want to get a baseline ultrasound after 2 weeks, and then you can just monitor for the patency of the TIPS via ultrasound subsequently. So moving on to BRTO, BRTO stands for balloon occluded retrograde transvenous obliteration. What you're basically doing is sclerosing the gastrorenal shunt, and we mostly do this to treat gastric varices. So just to go over the complicated anatomy here, when you have portal hypertension, you get retrograde flow of blood into these gastric veins as well as short gastric veins. This pressurized system results in gastric varices, which tends to decompress through a gastric renal shunt, which communicates with the left renal vein, and then blood is returned into the systemic circulation through the IVC. So when we're doing this retrograde obliteration of the shunt, what we're doing is accessing the IVC and getting into left renal vein, accessing the shunt, and retrograde, taking down the shunt as well as the gastric varices by injecting agents such as sclerosant or gel foam. So the indication for doing BRTO is primarily treatment of refractory gastric variceal bleeding and the presence of a gastrorenal shunt. Taking down this shunt can also help in patients that have hepatic encephalopathy, and it can be very effective. There are different versions of a BRTO, and such as CARTO, where you're using coil embolization and often gel foam instead, and then PARTO, which is putting a plug here in the shunt instead of coils or a balloon. The plug is limited by the size. Often the sizes aren't large enough to accommodate the shunt in place. And so this is just a schematic drawing of, putting a balloon catheter in that shunt, and then injecting sclerosant, which should cover the shunt, the gastric varices, and the endpoint, which is that feeding gastric vein. So gastric varices is seen portal hypertension in 30% of patients. It has a really high mortality rate of 45%. Unlike esophageal varices, it has a tendency to rupture at a lower pressure. The gastrorenal shunt is seen in greater than 88% of patients with gastric varices. So gastric varices are really hard to treat endoscopically, especially the ones that are located in the gastric and fundus. Creates a really difficult angle for interventional GIs to go in and perform band ligation or even sclerosant. You know, when you perform a TIPS, you are decreasing the portal system, portal hypertension within portal portal system, and this tends to be effective for the treatment of esophageal varices, but this isn't effective for gastric varices. So just going over the treatment options for gastric variceal bleeding and how effective they are, you know, endoscopy, like I discussed before, you know, it's risky because you can create embolism, perforation, and there's limitations of treating this because of the angle. It has a really high rebleeding rate of 50 to 90%. Surgery isn't a great option for these patients because, you know, they tend to not have reasonable liver functions and don't have, they aren't great surgical candidates, has a really high mortality rate of 42 to 56%. TIPS is a lot better. The rebleeding rate is 9 to 23%, but it's not recommended for people that have, you know, high MELD scores, hepatic encephalopathy, or, you know, hepatic insufficiency. And then we have BRTO, which is highly efficacious, you know, success rate of 87 to 100%. The rebleeding rate is less than 10%. And the good thing about BRTO, you can do this procedure in patients with poor hepatic reserve and who tend to be encephalopathic. It's also very less invasive because you're entering through the systemic venous system. One thing to note is because you are taking down the shunt, you are increasing the portal pressure. So later on, these patients can have other sequelae like developing esophageal varices after this procedure. So when you want to evaluate a patient for BRTO, you know, you want to look at their liver function, evaluate the renal function, but most importantly, you want to look at imaging before you do a procedure. It's important to make sure that there is a gastrorenal shunt for you to embolize, and, you know, definitely measure the shunt for pre-procedural planning. So to do this procedure, you want to get either, you know, femoral or jugular access into the IVC. You want to use the balloon catheter and, you know, place it within the gastrorenal shunt via the left renal vein. And then from here, you want to inflate the balloon so it creates a backstop, and then inject a sclerosing agent, which is composed of air, some foam, and Lipiodol. This injection is done slowly, and it should fill up the shunt, the varices, and then back into the feeding gastric vein. And then when you see the sclerosant within the gastric vein is when you really want to stop, and you know you've have sufficient treatment. So when you use BRTO and you inject sclerosant, it is a very toxic agent. It causes inflammation within the venous walls and, you know, shuts down the vessels that it's used to be treated. Because of this, it's really important to have the patient stay in an area where they can be frequently monitored. So the ICU, CCU, or ER. Preferably, the balloon inflation time is 2 to 36 hours. The average time is 6 hours. This procedure is 2-stage, so, you know, it takes approximately 6 hours for this sclerosant to work and form a cast. You know, you want to bring the patient down. You want to aspirate the sclerosing agent and slowly deflate the balloon. What you're looking for is a firm cast and complete confirming that there is complete treatment of the varices, and then after that you can deflate the balloon. If there's incomplete casting, you have to reinflate the balloon and just wait some more and bring down the patient at a later time. Carto is a more preferred technique. What you do is access the shunt the same way you would for a BRTO. it's a 2-catheter technique where you get access distal into the shunt and varices with 1 catheter, and you have another catheter that's more proximal. With the proximal catheter, you're basically coil embolizing the shunt. So you create this backstop. And then with the more distal catheter, you're injecting gel foam, contrast slurry with the same type of technique that you would use for sclerosant. So the benefits of using, a CARTO, there's no indwelling balloon, it's less toxic, and, unlike PARTO, there's no limitations to the plug size. It is safer with less complications, and, it's just one procedure. There's no, you have to worry about ICU bed or bringing down the patient later, because this works immediately. So in order to do this procedure, you have a 710 French sheath that you advance into the left renal vein. You want to do a left renal venogram to kind of identify the shunt and map out where the left renal vein is. You want to get retrograde access into the gastrorenal shunt and perform a venogram. And you can do this with a balloon catheter because, the flow is going this direction. The occlusion is necessary to better identify the shunt. This is when you want to do your measurements, and these measurements are really important, for coil embolization, creating that appropriate backstop. So like I just discussed before, the distal catheter does gel foam injection, and this creates a backstop. Before embolizing, you really want to inject contrast and make sure that this coil is being really effective in preventing any flow into the left renal vein or IVC. And then here's an example of BRTO or CARTO. You have this coil here creating that backstop. You have, the gel foam slurry agent in the gastrorenal shunt extending to the gastric varices and then into the feeding vein. So some more images showing the treated gastric varices and then the feeding vein, which is the appropriate endpoint. So after you perform BRTO, you want to get a CT a couple days after the procedure. Especially with BRTO, you want to evaluate for complications. You want to make sure the sclerosant got into the renal vein or IVC and embolized into the pulmonary arterial system. And then most importantly, after the BRTO, these patients do have, increased portal hypertension, and you want to make sure that, you either follow it with CT or endoscopy to make sure that they aren't developing any esophageal varices. And if they do, they can be subsequently treated for they enlarge to a dangerous side. So BRTO is really effective. On the left here, you can see the endoscopy images of gastric varices prior to treatment, and to the right, you can see how effectively it was treated in endoscopy 6 months after. All right, thank you for signing in today to listen to the lecture. If you have any questions, you can email me below or message me via Twitter.
Thank you, Dr. Kumari. Those are excellent overviews of TIPS, BRTO, and CARTO. Next up, we have Dr. Glen Hoots, who is with the University of South Florida and is the program director there, and he'll be talking about interventional oncology.
Hey everybody, thanks for having me this morning. Sorry, I'm also on a physician's retreat for our hospital leadership. So I'm sitting outside. I'm actually on the Yankees practice field here in Tampa. So we're going to talk a little bit about interventional oncology. Can everybody hear me okay?
Yep, we can hear you.
Perfect. All right. So, I didn't want to bore you guys with too many details. I wanted to try to give you guys a good overview. You've probably on med student rotations and things, if you've been around some of the some IR departments, everybody's doing a lot of Y90 radioembolization these days and some microwave embolization, but it's not all that we do. And each one of these different therapies has a different fit in different malignancies, but also depending on what else is going on with the patient and in particular clinical situations. I had case examples of each, but I mean I could literally talk about this for hours, so I kind of kept it just to some cooler cases and figured I'd go through these things as an overview. So like bland embolization is something that we use in either tumors that are bleeding. Like let's say somebody comes in with a ruptured HCC, you usually just do a bland embolization. You don't do a chemo embolization for that because your goal is really just to stop the bleeding at that point. You're not necessarily treating the cancer. We do it a lot in, osseous malignancies where they're worried about blood loss in the OR. So we'll do things like, tamponade balloons, but we might also embolize the tumor. And then another place where bland embolization really fits in is for neuroendocrine liver mets in patients that have, serotonin syndrome from, release from those tumors. And you use that basically to treat their hypertension. You bring them in, you embolize the tumors, you decrease their tumor burden a little bit, and their hypertension gets better. For a while, some people were really trying to treat it aggressively and doing things like Y90, but the outcome was shortened lifespan because every time you treat somebody with Y90, not only are you, killing tumor, you're sacrificing portions of the liver, and then you would send these people into liver failure early and they'd die. So Y90 is really not appropriate in that setting. So TACE or, transarterial chemoembolization works great for HCC. It's not curative, but it keeps people, in a stage where you can transplant them eventually. Y90 radioembolization is great for a variety of malignancies, especially metastases, but, most of the applications for it are not curative. If you're doing a whole or a half liver Y90, you're generally not doing a high enough dose, to get a segmentectomy or a lobectomy, because you have to balance how much liver tissue you're willing to sacrifice with how much tumor you're going to be able to kill. So in those settings, it's not curative. When you've got, a lesion or lesions confined to a certain portion of the liver that you're willing to sacrifice, then you can do a really high dose and get a curative result at the cost of sacrificing a portion of the patient's liver. And then other things like, cryoablation, which we use either in tough spots or we use in RCC mostly at our institution. Microwave ablation that we use mostly for the liver, and part of that is cryoablation in cirrhotic patients, and most of our patients have HCC, and so they're usually cirrhotic. They can have something called cryoshock, where they actually they go into shock after ablation of their liver, and it's just something that happens in cirrhotic patients. Microwave ablation is great because it's quick. Irreversible electroporation is something that we've done before with image guidance. We still, from time to time, assist our surgical colleagues with that in the OR, and we usually do it with an exploratory laparotomy and then place the probes under ultrasound. But it actually kills the cells, but leaves the surrounding, extracellular matrix, so tissues kind of stay intact. So you can use it in really sensitive areas. The main place that we use it is the pancreas. But it's very difficult to place these probes. You have to pair the probes. They have to be placed parallel and a certain distance apart to actually have it work. So it's much more, time efficient to use microwave ablation unless there's some structure adjacent that you're really worried about. And in those cases, we generally use cryoablation. So cryoablation and IRE can be used interchangeably in most settings. And then a very new technology that we were on the study for, histotripsy. So it's the easiest way to explain it is it's something akin to high frequency focused ultrasound or HIFU. And it's different, but very similar, where you're using pulse waves that actually cause the cells to die. And it's all external. There's nothing implanted. You do it with ultrasound guidance. But as it stands right now, it's not ready for, commercial deployment. It's pretty complicated. It takes a long time. You have to put the patient under general anesthesia, put this huge water bath over their abdomen, and then put this, big probe head in place over their abdomen and target the lesion. So, I've kind of already hit on most of these, but our commonly treated malignancies for us at our institution, given that we're a big transplant center, hepatocellular carcinoma is number one, renal cell carcinoma is a close second, cholangiocarcinoma is third, and then we see a variety of metastases. We used to see a lot of colorectal cancer metastasis, but as data came out on Y90 and colorectal metastases, it's really only shown to be of great benefit in patients with a right-sided malignancy, ascending colon or cecum. And other than that, it's not a first-line therapy. And as other chemotherapies have been developed, they've shown better results. So we don't see as many of those as we used to. All right, so the first case I wanted to show you guys, this is a 50-year-old female. She had colorectal cancer with liver metastases. She's had 6 or 7 rounds of chemotherapy. She's been on everything. She's had FOLFOX, FOLFIRI, she's had Avastin. And, despite all of this, her liver metastases have persisted, not responded to any chemotherapy. And she didn't have any other measurable disease outside the liver. So she was referred to us for a Y90, mainly because she actually wanted to take a break from chemotherapy. So when you decide to do a Y90, we're looking at, where her disease is. It's mostly localized to the right lobe. She does have lesions in the left lobe of the liver. So it's going to end up being a bilateral treatment. So as far as dosimetry goes, you're really looking at doing a lower kind of standard dose. If you're using, SIR spheres, you're going to target, 60 gray or so to the area. And if you're using TheraSpheres, you're going to target 120 gray. And, the difference in the number is mainly due to the difference in the calculation of the dose, not necessarily the total radiation dose that you're delivering. So then the first thing you have to do is you have to bring them in for a mapping procedure. And so you're doing this mapping angiogram. And here you can see, this is a celiac arteriogram. You're really only seeing the left hepatic artery. So you know that there's something that's replaced. And so she had a replaced right hepatic artery that came from the SMA. There we go. There we go. So this is the SMA run. You can see from that CT that most of her disease was in the right lobe. So that all of that irregular enhancement there is all metastasis. And so given that we were planning on doing, both lobes, we mapped out the entire right, given that it was where most of the tumor was, delivered MAA, which is it's a technetium 99M labeled macro aggregated albumin. So it's just a protein with a radio tracer on it. And it, the size of the clumps of protein approximate the size of the beads that the Y90 is loaded on. So we use that as an analog. And, you put that in the artery that you're going to treat, barring, seeing any other accessory arteries that are coming off of these arteries. If you see any accessory arteries on the mapping angiogram, you go ahead and coil those off. I've got another case that I think I show next that's got some phrenic arteries and gastric arteries and things coming off the hepatic arteries. So if you see them on angiogram, you go ahead and take care of them, and then you go ahead and place the MAA in there. And on these post MAA images, you're looking for, you know, the degree of shunting to the lungs, which you actually measure and get the geometric mean, and then decide how much of the MAA made it through the liver and into the lungs. They used to have hard cutoffs where people said, you know, if it was over 15, you couldn't do it, or you needed to reduce the dose. But realistically, as we do more segmentectomies and things, you play with that dose a little bit and try to keep the lung dose in a safe range based on that shunt, rather than just saying, you know, the shunt is this high, we absolutely can't do it. So here you're also looking for any activity that's outside the liver, which we don't see. Sometimes there are small gastric arteries or things that are collateralized that you don't see on your mapping angiogram that pop up here, and then you would go ahead and you know, do another angiogram, try to find them, or possibly not even do the treatment. But here everything looks good. We've got a lot of activity in these metastases in the right lobe and a little bit of activity in the left. So on her 3-month follow-up, we actually saw an increase in this this lesion centered within the liver. There's an overall decrease in some of the other metastatic burden in the right lobe, and we decided that the answer would be to repeat a Y90. She absolutely did not want to go back on chemotherapy, and really just requested, like, you know, hey, can you do this Y90? Given the size of her left lobe, she was going to have enough reserve, so we decided we'd pursue that. And so on her repeat mapping angiogram, on you know, this proper hepatic run, you can see that we've got the GDA here. So given that I was going to retreat that large tumor in the center of the liver was actually mostly supplied by segment 4. We were going to need to treat it from the left because that's where the segment 4 artery arose in her. It can be off the left or the right, depending on the patient. We coil embolized the GDA just as a protective measure. It's something we used to do as a standard in all Y90 treatments, but nowadays it's kind of optional. On the run after I coiled the GDA, you can see there's a little spasm of the left hepatic artery proximally, probably just from catheter manipulation in the coils. But there's a right gastric artery arising from the proximal left hepatic artery. So that would also be dangerous should we reflux. And then arising from the left hepatic artery, there's also a left inferior phrenic artery. So we coiled the right gastric artery. We got into the left inferior phrenic artery and coiled it. And on our post embolization run, we had a complication. So, you know, these things happen, but this one was pretty interesting and just increased the difficulty of this case even further. So when I did my post coil embolization run here, you can see that you don't see any other branches in the left hepatic artery anymore. And what had happened was when we coiled the left inferior phrenic artery, at some point it lifted a dissection flap. And when I did my post angiogram, it propagated that flap proximally. So it dissected the entire left hepatic artery. So I was kind of at a loss. You know, I delivered MAA and we figured we'll see what happens and we'll go from here and decide whether or not to treat. So day of treatment, we did this angiogram ahead of time. Here's the left hepatic artery. You can see most of the branches are pruned off and you can't really see anything. But what I did was I knew the location of the segment 4 artery based on the prior angio. And I actually picked through and recanalized the segment 4 artery. And we delivered the Y90 here. So this was her follow-up scan, and we have both an MRI and a PET CT, and you can see that, you know, it's hard to compare to the CT sometimes, but that large lesion that she had centrally in her liver has now significantly decreased in size. It's probably, you know, a half to maybe even a quarter the size it was. And then the PET shows us what tumor was actually still active, and it was significantly decreased. But, you know, a really tough case with, you know, a little complication, but we managed to kind of pull out a win there. Because in these colorectal patients, the goal isn't to get them absolutely disease-free, especially with the disease burden that she had to start. You really just want to get their disease under control, give her a little break from chemotherapy, and hopefully extend her life by decreasing her metastatic burden. So case 2 here, we've got a 40-year-old male with cholangiocarcinoma. He had a prior Y90 at an outside institution, and this was his follow-up scan, and it really didn't touch the tumor. So they referred him over to us to see if there were any other options that we had for him. You know, some other factors that made it a little bit more difficult was that this gentleman was, he was 6'4" and about 450 pounds. So really, really big guy. So we get set up to do our initial mapping angiogram on him, you know, figuring that we're going to do a repeat Y90, that would be the best. I got the records from the outside institution. When we reviewed what they did, they had just underdosed him, you know, severely underdosed him, and that's why it really didn't do anything for the tumor. So we bring him in for the mapping study. We decide he's such a big guy, we really don't want to stick the groin. And then he also, you know, preferred that we access radial. So we look at his left wrist, and he had a prior complication from the previous angiograms that he had from the prior Y90. And he's got this big radial artery aneurysm here. But without, you know, really having any other access, and he didn't have any symptoms related to it, we went ahead and re-accessed the radial artery aneurysm. On the angiogram, you can see that there's, you know, deformation of the vessels here that are splayed around this large cholangiocarcinoma that's central in his liver. And also, I've actually got this is one of our radial catheters that we borrowed from cardiology. I can't remember whether it's a Sarah or a Jackie, but, you know, this gentleman was just so big that when we got him on the table, and I originally put a microcatheter out, we were doing runs through a microcatheter with, you know, our preferred contrast that we use for arterial cases, and it literally just wasn't enough. You couldn't see what was going on in this guy, just because he was so big. So we switched contrast to a higher osmolality contrast, but I actually put the 5 French catheter all the way out his left hepatic artery to do the run, and you can still not see very well despite, you know, DSA and increased osmolality contrast and everything. But, you know, we felt comfortable mapping him out. And then we followed him up, and you can see that this tumor, where it was kind of mixed before, is now it's decreased in size. It's largely hypodense. So we had a pretty good response to the initial treatment. But he also said that, you know, one of his few activities he could still do that he enjoys is he, you know, fishes some of our rivers and canals here in Florida. And he said every time he casts his fishing rod, it hurts. Well, on the follow-up scan, he had this large rib metastasis here and was having pain related to that. So given that, you know, we have options for that, I offered him a cryoablation to both, you know, try to ablate the tumor and ablate the adjacent nerve and help with the pain. So we brought him in. This was our planning scan. Once you guys get into your, you know, radiology residencies and start to look at scans, you can see that this scan is overall photon deprived, hence the artifact here in the middle where you see this swirl. And then under CT fluoroscopic guidance, we placed probes to do the cryoablation, which was very difficult just given his size and artifacts on the scan. And so that was after placement of the first 3 probes. It's hard to tell just by looking at the scan, but this lesion's about 8 centimeters by 4 or 5 centimeters wide, because he's a big guy. This is a big tumor. So we ended up putting, I think, 5, maybe 6 probes in this thing. There's the image with the ice ball. So we can see that we are, getting a little bit of lung tissue and a little bit of adjacent liver, but wanted to make sure we had sufficient coverage of the tumor and the adjacent nerve. And then that was our post. No bleed, no pneumo. And so after this gentleman, he went back to fishing, lived another couple of years, and had a much better life. Our third case, this is a 40-year-old female, alcoholic cirrhosis, multifocal hepatocellular carcinoma. She's got, at least on these images, there's this kind of tough lesion to see. Alcoholics tend to have really nodular livers with a lot of regenerative nodules, and it makes the diagnostic portion of things pretty difficult. But there's this central lesion here. There's the washout we look for. You can see a little rim of enhancement around it, which is a pseudocapsule. And so same thing with this other lesion here in segment 4B. And so we brought her in for her. We decided that, given the location of these tumors, that they were easily ablatable. And so ablation and Y90 segmentectomy are kind of our 2 curative options. So we opted, in her case, to do an ablation. With our ablations, what we generally do is we do a TACE prior to that. That way the Lepiodol stains the tumors, and they're much easier to see on the ablation. Plus, if there's any, kind of adjacent daughter lesions or anything, you can help get better coverage of those by doing the TACE first. So she also wanted radial access. So here's the radial access angiograms with the TACE. So another thing you really see in cirrhotics have very, very tortuous intrahepatic arteries. So now we finally see this is our segment 4B tumor. Good luck just based on this picture figuring out what artery it comes off of. So we did a little obliquity, did another angiogram. We're basically just hunting this thing down, trying to find it. And, we have other fun things now, like our cone beam CTs and things that help us trace these vessels and find these tumors. And so eventually it was tough to decide which artery the tumors were coming off of. So we did a chemoembolization of the entire right hepatic lobe, which is always an option when you have multiple tumors and you're just using Lepiodol. It's pretty friendly to the liver in general. And so then she came back for her ablation. And so on CT, we can see that there's really only focal staining of that pretty big central lesion. Like, we knew that this lesion was several centimeters big, but it's only, about a 1 centimeter area of it that's stained with Lepiodol. And then here's another lesion in the periphery of the liver, adjacent to our target segment 4B lesion that we saw in the prior MRI. You guys will learn about Lepiodol over time, but it's pretty cool. It's a thiodized oil, but what it really is it's just iodine in poppy seed oil. And given that normal liver tissue still has Kupffer cells, it'll take up that oil and get rid of it. Whereas the tumors, if they're not well differentiated, have lost their Kupffer cells, and the Lepiodol gets stuck in the HCC. So here we targeted that central lesion. We're placing the microwave probe. And then once we were kind of happy with where it was, we went ahead and ablated. Nice ablation zone. You know, you can ablate lesions up to 3 centimeters in diameter. You want to try to get a 1 centimeter margin around them. And basically, of the microwave probes we have, the biggest ablation zone you're going to get in one shot is up to about 5 centimeters. And so then we targeted the other lesion. Given that the lesion was very close to the gallbladder, that was our objective, was to ablate right up to the edge of the gallbladder. We placed the probe a little deep, pulled it back, and actually it looks like we were going for the other edge of that other tumor to make sure we had sufficient coverage. And then I must have missed the images with the ablation of the other tumor, but you can see that there's hypodensity surrounding this chunk of lapidol on that segment 4B lesion, indicating that we successfully ablated it. So she was followed up a month later. There wasn't any residual tumor, and she ended up getting a liver transplant and still floating around. When I pulled those images, I think we just biopsied her liver transplant a couple of weeks ago. So this fourth case, 60-year-old female, history of rheumatoid arthritis. She's on long-term corticosteroid therapy, has chronic kidney disease. They found an incidental 4-centimeter renal mass. She was offered nephrectomy, but was basically told, if you get a nephrectomy, you're probably going to go on dialysis. She happened to be a physician. She knows the long-term risks and outcomes of dialysis at her age, and she really wanted to avoid dialysis at all costs. So she came to us and wanted a cryoablation, which, man, I thought I must have lost my picture there, but we'll look at it here on the pre-scan. So when you look at this, at her tumor, so she's got a rather large left renal mass here. She's prone in the scanner, but it is directly adjacent to her colon. So one of the tricks you can do is hydrodissection. So what we did was we went ahead and we placed our cryoablation probes and got those where we were happy with them. And then after that, we came in with a blunt Hawkins needle. So it's a blunt tip needle. So it really it won't puncture the bowel unless you really, push on it, but it'll push it out of the way. So we set that needle right in between the left kidney and the colon. And then we're injecting saline here. And you can see that we're pushing the colon out of the way. And once we kind of displaced that colon successfully, we went ahead and did the cryoablation. And so here you can see our ice ball. Well, actually, we added another probe. So then there's our ice ball with good coverage of the lesion. Here was our final ice ball to make sure that, we still were away from the colon. And then our final after removal of the probes with no bleed, sufficient coverage of the mass. We usually don't do all of the reconstructions when we're doing ablations, but on her, just given its proximity to the colon and everything else, we wanted to make sure that we had sufficient coverage. So we did all the recons while we were in the room to make sure that we got coverage of this thing. Now with her, we did get sufficient coverage of the lesion. She did pretty well the day after, but once we discharged her home, she called us back and she was actually having severe lower extremity pain, in her ankle. And it's an interesting case that we actually published. She, from tumor lysis syndrome, given her renal insufficiency, she developed gout post-procedure, which was just pretty cool. So if you guys, if you look me up, that's one of the case reports we have out there, and it's just a pretty neat case. Do you guys have any questions or anything on what little time we have left?
Thank you, Dr. Hoots, for the overview of IO. I'll try to find that case report and link that for everyone. The Y90 cases are always my favorite. But so next we have Dr. Sid Padia from UCLA, and he'll be telling us about some MSK interventions.
Thanks for the invitation. I'm going to try to share my screen here. Okay, so I'm not going to give a big, broad overview of MSK interventions. I'm going to talk about one specific topic, and that's called genicular artery embolization for knee osteoarthritis. And I think part of the reason which got me interested in this is that when I was, the greatest thing about, actually the best and worst thing about our field, interventional radiology, is that it changes so much. So what I did as a medical student and even as a resident is entirely different than the types of patients and procedures I do today, 14 years later. And this is an example of it, because this procedure, this therapy was frankly just non-existent 5 years ago. And we are close to making this standard of care. We're probably at 2 years away. So these are my disclosures. And I'm going to start with one case. I'm not going to go through too many cases, but just to give you kind of a flavor of what we're doing here for knee arthritis. So this is an 89-year-old guy. He had pain in the right knee, and you can see the X-rays here. So the right knee is on the left side of the screen, and you can see that lateral compartment is quite narrowed. And so he underwent conservative therapy with joint injections. He's 89 years old, so he can't really go undergo a knee replacement because he's got multiple other medical issues where he couldn't undergo anesthesia and so on. He fills out this score. This is a scoring sheet called WOMAC. It's a pretty well standardized scoring system for people with arthritis. And he had a score of 56 out of 96, which is quite high. So when we think about arthritis, and I'm guessing as medical students, you probably received between 0 and 1 lectures on osteoarthritis, because frankly, it's not very exciting, right? So we think of osteoarthritis as this wear and tear disease, similar to, the brake pads running out in your car. And that's what it's always been viewed as. And over the last 10 years, there's hypothesized that there might be some low-lying inflammatory process going on even in OA. And so you can see by this diagram, everybody in the audience probably knows this better than I do, since I'm far removed from rheumatology and kind of the inflammatory cascade of all these inflammatory enzymes going on, which is implicated within the synovium of the joint. So if you can stop this process here, maybe you can stop the process of pain. And they've shown this even in pig models using electron microscopy and so on, that when you get synovitis, you get this increased surge of inflammatory enzymes. So the goal is to stop this inflammatory cascade. It's not to restore the joint, put more cartilage, shove meniscus in, et cetera. So how do we do this? So it's done in the interventional radiology suite. It's outpatient. It's done with sedation, or they can get even just a local anesthetic. So there's no anesthesia involved. It's a pinhole puncture in the femoral artery. Dr. Hoots showed a bunch of Y90 cases, and those are a 5 or 6 French sheath. This is a 4 French micropuncture sheath. So the diameter of the arterial puncture is less than 1 millimeter. Okay, so you're looking at a 1 millimeter or less puncture in the femoral artery. So we put that sheath in the femoral artery. And just as a very brief review, I'll be honest, I didn't learn this in my anatomy class in med school. It's like learn femoral artery, popliteal artery, and then your tibials. And in your knee joint, you have about 6 branches going to your knee. You think about them as quadrants. So superior medial, superior lateral, inferior medial, inferior lateral. Then you have one coming in from the top. That's the descending genicular. That supplies the medial aspect of the knee, and then one coming in from the bottom, and that's the anterior tibial recurrent, and that supplies the lateral. So now you have 4 quadrants, one from the top, one from the bottom. And so this is an angiogram. So we have the catheter down in the femoral artery. And so this is an angiogram of the popliteal artery, and you can see this one artery going lateral to the left side of the screen, and you can see this faint BB marker, which we placed on the skin. So we go ahead and select that one. And you can see this C-shaped vessel. That's the inferior lateral genicular artery, and that's normal. but there's this triangular area of hyperemia right next to that circular marker. So that's the abnormal part. That's the inflammatory response of the synovium. And the goal is to eliminate that. So from here, we inject a very small amount of tiny particles called, in our case, we use something called Embolization. There's, half a dozen different manufacturers. They're all more or less the same. And the end result is this. So you still have that artery and you're just getting rid of that inflammatory process. Okay. And so that's it. And, start to finish, this is about anywhere from 1 to 2 hours. So this guy goes from a WOMAC of 56 to 26, but let's be honest, none of us really care about WOMAC scores. You want to see if this guy gets better. And remember, this is an 89-year-old patient, and he comes to my office 3 months later, jogging in place. And before, he could barely make it for 3 blocks. I did this guy in 2017. I saw him 3 months ago. He is 5 years out. He is 94 years old, and he is still pain-free after a single infusion back in 2017. So he has a 5-year duration. So where's the evidence for this? So now we have 4 or 5 prospective studies. I've only listed the prospective studies here, not the retrospective ones. You can see the age ranges. The severity is on a scale of 1 through 4 in terms of their knee radiograph. So 4 being the worst, 1 being the least. We use different embolic agents to block up the artery. The initial paper was done in Japan by Dr. Okuno. He used imipenem, which is, as we know, an antibiotic. So he used a crystalline form of that, which frankly is not really readily available in the United States. So for us, I used a permanent embolic, which is on our shelf. And you can see the success rates on the right. Right, so we're looking at anywhere from like 60 to 80, 85% success rate. So what we did was, this is Dr. Okuno's initial paper. This kind of launched this whole field. Okay, so he did this single arm trial, prospective, 95 knees in 72 patients, age 40 to 80. They've had to have standard of care therapy like nonsteroidals, intra-articular injections, and so on. And you can see the WOMAC score on the top. The average was 43. Remember, this is out of 96. So 43 out of 96, going down to 24. And then you just look at this gradual decrease over time. This is lasting out at 2 years. And you can see the pain score on the bottom row, that's a scale of 1 to 100, going from 72 out of 100 down to 14. What I also thought was fascinating in his study was that he had a lot of patients on daily opiates. Okay, so he had 20 out of the 72 patients on narcotics on a daily basis, and he had a 90% reduction in opiate use. And we all know how big of a problem opiate use is in our country. So if we can achieve a 90% reduction in people needing daily narcotics, I think that's a win. So why this is actually sustained. So this guy actually went to, a part of a study, underwent an angiogram about a year later. So you can see the initial angiogram with all that gray stuff, which is the hyperemia, and then it resolves, and then even stays resolved about a year later. So let's back up. So I'll give you your what you actually need to know about arthritis. Okay, so I'm guessing that most of you as medical students don't have arthritis because you're in that age group of 20 to 29 or even 30 to 39. But once you hit 60 to 80, that's when the incidence of OA increases. In this graph, and even in my practice, I think it's much more predominant in women compared to men. I would say my best estimate is like 60, 40, maybe 65, 35. What are the treatments? It ranges from nothing to all the way to knee replacement. So nothing is, kick up your leg, rest it up on the couch, put an ice pack on. The medical management really consists of non-steroidals like ibuprofen or naproxen. Most guidelines, American or Westernized guidelines, recommend against the use of opiates or narcotics, which is pretty obviously stated. But we know that there are certain contraindications for nonsteroidals, and that's not a permanent fix. It's not a durable fix by any means. So then the next category are joint injections of a corticosteroid, and then finally knee replacement. So let's look at the data for columns 3 and 4. Okay, so for joint injections, this is an injection of cortisone or any corticosteroid, and there's dozens and dozens of trials on this. The nice thing is You can go to your primary care physician's office and they can do it. Sports medicine physician's office, they can do it. It's quick, it's outpatient. You don't need to be sedated. It's a tiny needle in and out of the office. It's relatively inexpensive. But this RCT prospective, you can see that they compared it to a placebo, and I can't honestly tell the difference between the red and the orange lines here. There's basically an effect with placebo as well, which is equivalent to corticosteroids, both short-term and even long-term. These guys published in New England Journal of Medicine 2 years ago. This was done in the military system. They compared physical therapy to glucocorticoid injections. They actually found a better benefit in PT versus intra-articular steroids, which you can see here. This was, a randomized prospective trial. Now, keep in mind that when we talk about physical therapy, in reality, let's say in my practice in Los Angeles, getting patients physical therapy is actually not that easy. Every PT is different. Every center is different. Every insurance is different. So you can do that in the military system where everything is, much more reproducible, but it's harder to do in the rest of the world or in the rest of the country. Okay, so then let's go to total knee replacement. Knee replacement, there is data. There's actually quite good data to show that this helps patients. There are, as you probably know, and you may have rotated through orthopedic surgery. This is kind of what I would consider a bread and butter procedure of orthopedic surgeons. But it is commonly performed, a high aggregate charge. This requires a considerable amount of rehab and recovery. So again, I pulled this out of New England Journal. This is actually from a Danish group. They randomized patients. It's obviously not placebo controlled, but the patients in the knee arthroplasty group did significantly better, both statistically and clinically, compared to the non-surgical group. Keep in mind, there are some adverse events, mostly commonly DVT, and this has a lifespan. So you get a prosthesis, you're looking at about 10 to 20 years of the prosthesis. So we did this, and we published this last year in Journal of Bone and Joint Surgery to look at genicular artery embolization, because what we need to do is get data, prove that this works. We did a single arm trial. We wrote it ourselves at UCLA. We actually got UCLA Health to pay for all the procedures because we weren't able to get funding otherwise. And it was 40 patients. We wrote this protocol, submitted to the FDA. And so this is pretty kind of standard stuff for eligibility, age 40 to 80, which you'll see on the left column. That Kellgren-Lawrence score, which you also see on the left, that's that knee x-ray severity, which I'll go over in a second. The baseline demographics you can see here. So on the right side, you can see that grade 4, which is severe osteoarthritis, is 40%. This is a very brief review of that grading system, which I keep on talking about. There's grade 1, 2, 3, and 4. And just think of it as, grade 4 is bad, which is quote unquote severe. Grade 3 is moderate. Grade 2 is mild. Grade 1 is hardly anything. I'll skip some of the numbers here in the sake of time. We did have some adverse events. So this is what happens when you're trying a trial, when you're doing a trial, you're learning for the first time. We got these patients with these skin ulcers, right? So these are like 1 centimeter in diameter. They were pretty superficial, but very painful. We figured out actually how to avoid it after about 6 or 7 cases. So what we would do is during the embolization, what we noticed was that there were some branches going to the skin. So we were probably getting some particles into the skin. And so what we did was we put an ice pack on the skin for the embolization that vasoconstricted the arteries. And so now all the flow was redirected within the joint. And so we didn't have any after we started putting an ice pack. We also had some 2 bone infarcts. This is an MRI, and you can see this oval kind of island in the tibia, which is a little bit of necrosis. So these were asymptomatic, and they happened in 2 out of 40 patients. Okay, so most importantly is that WOMAC score. So we started with a median of 52, and we went down to 19 at 6 and 12 months. Okay, so we had about a 60-70% reduction in the WOMAC score. So what we wanted to do is the way we defined it is people had to have massive improvement in their pain and function, and that's what we were able to achieve in 68%. So 2 in every 3. So 1 in every 3 doesn't work. 2 in every 3, it's a profound effect. I'll skip all the numbers in the interest of time. But so this trial met its primary endpoint of safety, very low adverse event rate. We figured out how to fix the skin ulceration, and then a marked decrease in pain and function. This is not ready for prime time yet, right? So now we're figuring out a bunch of things. So we're doing this 3D imaging on the table, which you can see here. This is what's called a cone beam CT. So we inject contrast. The X-ray system moves in 180 degrees around the knee. And so it makes a 3-dimensional image of the knee, so we can figure out what arteries to go into. We started using smaller microcatheters and various other techniques to refine it. We still have a ton of questions. I showed one of the slides earlier about corticosteroids, that there's actually a placebo effect. So when I show this presentation to orthopedic surgeons, they're like, well, there's a placebo effect. So what we need to do are randomized trials. We need to randomize this therapy versus something else, which is what's typically done in most of, let's say, internal medicine. It's not done in surgery, but we have to get there to do that. And so we have still some technical issues to resolve before we embark on that. What we do know is, and this is a meta-analysis, a systematic review that was published, that the multiple trials are showing relatively consistent and reproducible results across the board, and these are in multiple areas of the world. Okay, so we then did this analysis. You came up with a new procedure. Is this going to work, right? And we came out. So we had actually a market research firm do this for us. They looked at a bunch of things. So I'll give you a couple of examples. HAE for liver cancer. Dr. Hoots talked about embolization. So that's what that is. So we can compare it to that. Green means good, red is bad. So is there a large population? Well, if you're on this call and you have parents, there's a good chance that one of your parents has arthritis, right? So we know how common osteoarthritis is, let's say compared to obesity or enlarged prostates or liver cancer. So it's very common, and especially compared to, let's say, prostate embolization for BPH. Well, arthritis affects men and women, and it affects your right knee and your left knee. So automatically, it's 4 times the incidence of enlarged prostates. Will they seek treatment? These patients are highly motivated because it is a significant limitation to their lifestyle. There are, that bottom row, are there competing therapies? This is something that we in IR fail to think about repeatedly. So let's say for prostate artery embolization, which Dr. Bhatia is going to talk about, there's a bunch of other things that urologists can offer, things like prostatectomy and TURP and UroLift and HoLift and so on. I showed you the data for knee arthritis. It's relatively scant. There is really nothing else in the space in the last 25 years. So the algorithm for treating knee OA in 2023 is the same as it was in 1993. Nothing has changed in 25 to 30 years, which is actually quite disappointing. So I'll give you another example to see what the potential is. This is a patient with very severe arthritis. You can see a little bit subluxation of the femur on the tibia. It's not perfectly aligned top to bottom. And she gave me permission to show these videos. You can see that she's walking, I don't know, maybe a mile an hour with a cane, hobbling, certainly not getting around. Okay, so we do the catheter in the femoral artery. We put these 2 BBs on her knee. We select the superior medial artery, genicular artery. You can see this hyperemia, and that's gone after embolization. And this is her 10 days later. So you can see her walking speed is about double. Nothing impressive, still wearing a cane, using a cane, but some improvement at 10 days. So this is her 1 month later. First thing you notice is she doesn't have a cane. So for the first time in 8 years, she is not using a cane to ambulate. You also notice that her walking speed is not 1 mile an hour anymore. It's between like 2.5, maybe even 3 miles an hour. So her mobility is markedly improved. You notice that she still has this limp, right? We can't fix that. We can't fix the structure in her knee because this is 2 months, right? So believe it or not, she's actually pain-free. She still has this limp, but no cane, and her walking speed is markedly better, okay? And so this is pre and post. Okay. And I would say that while she's never going to be like she was when she was 18 years old, the impact on someone's life when we can do this off of a 1-hour procedure without anesthesia is pretty profound. You know, other than the scoring systems and the data, this is what patients come back with, right? Like, took my granddaughter out for walks. I can walk from 3 blocks now to 3 miles. You know, can you do this for other joints, which I'll talk about in a second? I'm up to 5 miles on my bike. I dropped 25 pounds because I can start walking. So I didn't actually ask about the sex is easier part. I just took it for what it was worth. Okay, so how do we do this at UCLA to do this trial? It was actually extraordinarily hard. As interventional radiologists, one of our challenges in our profession is that no one knows what we do. Even my mom and dad still don't know what I do. It's actually incredibly challenging to explain it to them when you explain to lay people. So I went out into the community. I basically hit the pavement and gave educational seminars to you know, retirement homes and community centers and senior living centers and so on. We put out YouTube videos. We put out Facebook Live videos. And so that's, we put it in the UCLA magazine. We gave brand rounds. And so that's one of the challenges in interventional radiology, that patients don't necessarily come to us. You know, we have to really push and educate our community to get patient referrals. Dr. Tummala talked earlier. He's honestly one of the best I've ever seen at doing that. Because if he doesn't do that, he's going to be sitting in his office twiddling his thumbs. Okay, so what's the next step? As I mentioned earlier, we have to do randomized trials. So this starts February 1. I said start date earlier, made a mistake, 2023. Okay, so we're going to randomize patients now. So it's a 100-patient study. They're going to get randomized in a 2-to-1 fashion to genicular artery embolization or to a standard conservative treatment arm. It's not a placebo trial. We just weren't able to pull that off. And this is a 24-month follow-up. And hopefully with this, if it's positive, we can generate some level 1 evidence. We're also doing other things. So we have an elbow artery study, which I'm not going to show images in the sake of time, but this works extraordinarily well. The same exact procedure for tennis elbow. Access the radial artery, go out about 8-9 inches, access the artery going to the elbow, embolize it, and patients have basically complete resolution of their tennis elbow within a week. And so this study will start probably in February or March as we just received funding. And that's about it. This field is super exciting. I love it because it's brand new and we've seen rapid growth, and the growth in this and the interest in this is really seen in our profession. You can't replicate, it's hard to replicate that in every other profession within medicine in terms of going from bench to bedside. Thanks so much.
Thank you, Dr. Padia. It was very engaging. It was really cool to see that case of the patients changing their walking ability over the 2 months. I think we have some questions in the chat. You want to answer those?
Let me pull up the chat. Hold on one second. Okay, so I see one question. So what are your thoughts on genicular nerve ablation? Okay, so I didn't mention genicular nerve. That's a great question. So genicular nerve ablation is where you basically take a probe, like a radio frequency probe, and you ablate the sensory nerves in the genicular sensory nerves in the knee joint. So there's like 3 or 4 locations, and we do that as well. We do that for people who have failed this procedure or people who are not candidates because of inclusion or exclusion criteria. In general, the genicular nerve ablation procedure is about a 50% success rate, 50, and it lasts for about 3 to 6 months. So what I find that it's it's an option, but it does not have the durability that we had hoped for. You cannot do it and then hope that someone's going to have durability for 2, 3, 4 years. That simply does not happen on a regular basis. In contrast, the GAE procedure, we're seeing people at 3 and 4 years out and they're completely pain-free. So, and that's, I think, why genicular nerve ablation has not really been incorporated into the guidelines. It's because the results have been relatively short-term.
Thank you, Dr. Padia. So next we have Dr. Jamil Shaikh from USF, and he'll be talking about biliary interventions.
Hey, can everybody hear me?
Yep.
Okay, great. Start. And let me go to share screen. Let's go here. Share that. Can you guys see my screen? I think.
It's still loading. Are you good?
Can you see it?
Yep.
Okay, great. Sounds good. So good afternoon, everyone. Thank you, Yusuf, and the organizers for this IR symposium for inviting me. I'm lucky enough to give the last presentation, I believe, before this first break. And I know this exciting morning has been filled with some great talks, and bear with me here as I try to get through this presentation. Biliary intervention is probably some of the most rewarding and satisfying procedures that we do in IR. And it's one of the spaces that's probably expanding the fastest, specifically in terms of cholangioscopy and in terms of innovation. I'll get a little bit more into that in my talk. This is a little bit of a challenging subject as I try to cover this as an educator, and I'm sure that some of the other speakers can also attest to this, because a lot of these subjects in themselves can be entire forums that you can go to, and that's how in depth our literature is. So I don't have any financial disclosures. So biliary interventions is one of my favorite procedures in IR. It's where we typically interact the most with the amount of physicians in the hospitals, and whether they're GI, hepatologists, surgical oncologists, transplant surgeons, internal medicine doctors, hospitalists, or those who manage, basically critical care doctors who manage cholecystostomy tubes and cholangitic patients. It's where most of our colleagues come to us because they can't do something, or they tried to do something and usually failed, sometimes even making a tough situation worse. Despite being considered one of the more older disciplines in interventional radiology, minimally invasive transhepatic or percutaneous transcholecystic, which means through the gallbladder interventions in the management of biliary diseases is an exciting area with many advances. A resurgence in percutaneous management of biliary diseases has occurred partly because of the growing liver transplant population, as well as large number of patients who have gastric bypasses and who are not typically amenable to ERCPs, and partly because of the recognition that percutaneous access sometimes provides a more efficient and effective way of accomplishing, a type of diagnostic or therapeutic maneuver compared to a less direct transoral endoscopic route. So of course, understanding the biliary anatomy is key and critical to this. And then after that, we'll review some of the more basic and more common procedures that IR do. And finally, we'll end with getting creative with some biliary interventions and some novel techniques as well as. Okay, so why is it that we get involved in the biliary system? By and large, there's the purpose of IR in biliary disease is to provide diversion of bile. Now that the cause of obstruction can be plentiful, it's probably beyond the scope of this talk. But the important thing to know is that if the bile is obstructed and it's unable to be internally drained via ERCP, this is where IR usually steps in. These obstructions can be iatrogenic, and that means that's usually caused by surgery. And the more commonly we see this in patients who get a cholecystectomy and there's inadvertent injury to the common bile duct. It probably happens more than you think it does. Or if they had some other type of pancreatic or hepatic surgery and there's a bile leak or things like that. But by and far, the most common cause is actually a malignant obstruction from a mass. Think about a pancreatic cancer that's sitting on top of a distal common bile duct, preventing the bile from escaping or emptying into the duodenum. We can also have benign strictures as well. For example, in patients that have prior liver surgery or biliary duct surgery, and there's scar tissue that forms around the anastomosis, and it basically acts like a quote-unquote mass that prevents the bile from escaping. But it's obviously not cancerous, it's a benign stricture. And then these things can be superimposed with or without infection, and usually infection is also a common reason of why we get involved in the biliary system. The most common infection that we actually encounter is infection of the gallbladder itself, right? And these are patients who are too sick most of the time to undergo cholecystectomy, and so they're called for percutaneous drainage. Now, it's been quite a while since I've read up on my general surgery literature, but I think the general consensus for surgeons now is actually trying not to operate on severely acutely inflamed gallbladders because of the amount of inflammation that is present not only in the gallbladder wall, but it becomes adherent to the colon and to the liver. So even in other patients who are otherwise healthy, they'll put a cholecystostomy tube in them, allow them to cool off and drain, come back in about 4 to 6 weeks, and do the surgery as an outpatient. Other reasons that IRs get involved in the biliary system are to gain access to the biliary system. So for example, for other advanced interventions, we're going to cover some of this, but for example, like a rendezvous procedure that we typically do with gastroenterology, they'll do an ERCP from below, and we'll do a PTC from the percutaneous side, and basically try to get our wires to meet where we can do a snare through and through technique from both above and below. Or if we're gaining access for a biliary endoscope procedure, for example, if we're trying to do a stone extraction or a laser stricturotomy, having a safe and reliable access for further intervention is also a reason why we get involved. And finally, the last reason why we get involved is usually where for diagnostic purposes. So basically we have needle access into the biliary system, and we want to elucidate how much and what of the biliary system is involved in the disease process. So this can include both malignant and non-malignant causes. So for example, if you had primary sclerosing cholangitis or biliary cirrhosis, of course, the primary imaging modality is going to be an MRI or an MRCP, but sometimes the disease process is in younger patients who are very mild, and in order to elucidate these things, we can do a cholangiogram. The more common reason that we end up doing them here at Tampa General Hospital is a lot of the times these patients have cholangiocarcinoma, and these patients are undergoing, or there are surgical candidates who are going to have a very large, extensive surgery done. And so a lot of times what you want to do is you want to really evaluate if the tumor extends into any of the residual tumor or a residual liver that's going to be left over. And if it is, the surgical margins have changed, right? So again, an MRI is very good at diagnosing a lot of this, but when to get to the nitty gritty, if you're trying to get only a few centimeter kind of information, a lot of the times cholangioscopy as well as cholangiogram is used for that. So very briefly, I'll go into the biliary anatomy, and this is a lot of the information that you can get from your M1, M2 years. The biliary system contains of all the organs that produce bile and transport bile, all the way from the hepatocyte down to the sphincter of Oddi, and as it dumps into the duodenum. When the liver secretes the bile, it's collected by the system of ducts, and it flows through the liver, through the right and the left ducts, and ultimately drains into the common hepatic duct. From there, the common hepatic duct and the cystic duct join together to form the common bile duct, and then that dumps into the duodenum. There's a lot of variation in anatomy that occurs naturally in patients that doesn't look like this picture that I am providing. Knowing this anatomy and variation is critical when you're doing advanced biliary intervention. But again, for the purposes of this talk, that's beyond that scope. So let's get a little bit more into what it is, how we gain access into the biliary system. And that procedure is called a percutaneous transhepatic cholangiogram. The PTC was first introduced back in the 1970s, and it was actually quite popular and is one of the more common procedures that IRs used to do in the 80s and 90s. With the advent of ERCP, the role of PTC has markedly changed in almost all hospitals, where it went from being a primary intervention to a secondary source or a fail-safe method when ERCP fails. As a patient, it makes sense. ERCP is a better modality choice. It's potentially less painful, potentially less bleeding complications. You don't have tubes sticking out of you, and it's easily repeatable if necessary. The problem is that with an ERCP, you're going retrograde and you're going up the common bile duct. Plus, the amount of turns that you have to make through your pharynx, through the stomach, through the first and second portion of the duodenum, and finally going up the common bile duct limits the operator in terms of how successful they can be. Finally, the last limiting challenge is the fact that the amount of contrast that they can inject never fully opacifies the entire biliary system. So you're never really able to get a good picture if you're trying to do a cholangiogram of what the involvement and what the anatomy of the biliary system is. So PTC still plays a vital role in almost every interventional radiologist's armamentarium of the procedures that they offer. Currently, PTC is used when ERCP fails, or if there's a very difficult cannulation of the ampulla, or if there's hilar disease, and so it's very difficult to get upwards. So let's jump into a few cases here. So this is the most common reason that we do these procedures, is that we do it for malignant biliary drainage. We typically do these cases when ERCP fails, or if the patient is cholangitic, or if the patient has intractable pruritus. So when the bilirubin gets very high, patients get very jaundiced, and that amount of bilirubin gets deposited in your skin, if some of you remember this from your biochemistry classes, and that causes an incredible amount of itching that these patients have. So one of the reasons that we actually do this procedure is for intractable pruritus. Finally, one of the other reasons that we do this procedure is because the bilirubin is so high that the patient can't get a chemotherapy. A platinum-based chemotherapy is usually what's used to treat pancreatic, biliary, or liver tumors that patients have to get treated for. So we see a picture in the top right of a needle that's being accessed. It's being used to opacify the biliary system. The way we do this is we take a very skin-thin 22-gauge Chiba needle. We basically essentially blindly jab it into the liver and puff and pull back until we opacify the biliary system. Sometimes this is very easy and you can get lucky and it happens on the first or second try, and sometimes it takes a lot longer than that. But once we opacify the biliary system, we can use a second needle typically, or if your access is good enough, to pass a wire into the biliary system, over which we dilate it, and then we place a tube. So the second case that I'm showing below that is an access that's gained from the left side. So it's through the left hepatic duct. Those are typically accessible, and because it's very superficial to the skin, you can see it with an ultrasound, and you can take a needle and directly enter a percutaneous or a peripheral bile duct, and then the wires pass down through the common bile duct, and you can see a picture basically down over here of where the common bile duct tapers and becomes very, very, very tight. This is the area of obstruction. This is the pancreatic mass that's sitting here and resulting in this apple core effect that you can sort of see to this distal common bile duct. After we get access, we pass a wire through this area, and once we pass into the small bowel, we place this drain. It's an internal external drain. So as you can see here, it connects from the outside of the patient through the biliary system, goes across the area of obstruction, and terminates finally in the duodenum. The entire length of the catheter, from the tip all the way up to about this radiopaque marker, if you guys can see it, it's right about here. I'm sorry, the picture's a little bit small. Basically is lined with small holes, and the purpose is to allow for passive drainage to enter into the tube, cross the obstruction, and naturally drain into the small bowel here. All right. So finally, one of the other type of procedure that we do is for benign biliary stricture. So this typically happens from chronic repeated infections, such as pancreatitis, or if a patient has a non-obstructing stone that's sitting in the common bile duct, and it just causes this chronic irritation to happen and you form scar tissue, or if the patient has had a prior biliary anastomosis. And that's this picture that we see here. This is a choledochojejunostomy. So we can see here, this is a normal picture of a common bile duct that empties into the duodenum down here. And so what they've done here is they've removed a portion of the small bowel and connected the half of the bile duct directly into the small bowel. And what this allows to do is for bile to drain directly into the small bowel, and so you don't need an internal external drain. The problem is that there's sometimes a bunch of gastric juices that reflux because of normal peristalsis up into the common bile duct, and it results in a stricture right here. So you get chronic repeated trauma infection to this anastomosis, on top of which this is a surgically created joint, or a surgically created anatomical feature, right? So normally or naturally you would expect scar tissue to form here, but again, with the assault of the gastric juices, you form this benign stricture of scar tissue, which could result in a very similar picture as to what we saw previously with the malignant obstruction. Now, the procedure is exactly the same. You would still have to get through this area, put a tube down into the small bowel, and result in internal external drainage. However, with benign strictures, you probably have to do a little bit, you have to get a little bit more creative, and you have to do something what we call a cholangioplasty. So we use standard balloons that Dr. Tummala basically talked about, and how to open up arteries. We could use those same balloons to open up these strictures and basically allow for drainage directly into the small bowel here. And so hopefully the goal is to get patients to be tube free. One of the most common and bread and butter procedures that we do is the percutaneous cholecystostomy tube, which is an external drainage of the gallbladder. So we diagnose it via an ultrasound, which is what you see in the top right. In the top left, and we can see that the ultrasound, we see a thickened gallbladder wall, some free fluid, some stones inside. This is clearly an infected gallbladder. You can see a correlating picture of a CT below that where we have a very angry and inflamed gallbladder. So we can basically take a tube, and we have to end that bile that's stored inside the gallbladder becomes infected. So we have to figure out a way to get rid of it. So very similar to how we do a PTC, but instead of draining the biliary system, we're draining only directly the gallbladder. So we'll stick a needle through the liver sometimes, and typically sometimes we might even go through transperitoneal, and we stick the gallbladder itself and put a tube into the gallbladder to drain out that pus and bile that's inside the gallbladder. Ultimately, we can use this access, if it's reliable enough, for us to do other interventions. So we see this picture on the bottom right where we have a tube inside the gallbladder, we injected contrast, and we could see the lumen of the gallbladder opacified. And more importantly, we see this very ratty appearance of the gallbladder wall, which is what we see when we have an acutely inflamed gallbladder. But the other important finding is that at the neck of the gallbladder, we don't see the cystic duct opacified because it's occluded. There's typically a stone that's there that prevents the bile from exiting, which is what results in acute cholecystitis. And so in this access, what we can do is, after the gallbladder has cooled down, if the patient is not a surgical candidate, there are two options that the patient is usually left with. Number one, lifelong, you have to keep this tube in. All right, because the bile, the moment that you remove the tube, there's approximately a 60 to 80% chance that the patient can get cholecystitis again. All right, so these patients are left with, chronically having to come in to have their tubes changed. They're sleeping with the tube, it gets pulled on their skin. It's a miserable way to live your life, especially if you're a non-surgical candidate. You typically a little bit older and you need help with these day-to-day activities of living. It becomes a nuisance. So one of the things that we do is that we can take a wire and get into the common bile duct and into the gallbladder, and we put a camera over that wire into the gallbladder to evaluate the gallbladder. We can remove stones because we can visualize them. We can use a laser, or we can use a ultrasound guided lithotripsy device, very similar to what the urologists use, to break up the stones, recanalize the entire cystic duct. And if we're able to drain the cystic duct, remove the obstruction out of the region of the region of the neck of the gallbladder, we're able to remove the tube. The patient's able to live a tube-free life. This is a picture of that. So here we have choledocholithiasis, which is stones that are present within the common bile duct, that you can see these filling defects. You have contrast that's injected into the picture here. This is typically an inverted single shot. That's why it looks different from here. So if you inverted this image, this is what it would look like. So you see these filling defects inside the common bile duct, which is very dilated. So these are called choledocholithiasis. We can basically take our camera and go down the common bile duct and basically do the same thing, where we remove these stones or push them through into the duodenum. This is what a cholangioscope looks like. This is a non-reusable, so this is the same one that we can autoclave and basically reuse, very similar to what the urologists use. And now there's an advent of that just recently came out, probably about 2 years ago, is disposable biliary scope. So you just open it, use it for that patient, and you can throw the rest of it away. And it's really rapidly changed the game in terms of diagnosing diseases, making our biopsies way more efficient and making them almost 100% yield on the first try, as well as removing these stones. So it's really, really expanded the role of interventional radiologists in a lot of these procedures. So here's an interesting case, and this is some of the more wilder procedures that we could do in biliary, and this is part of the reason why I love the biliary system. This is actually taken from Dr. Charles Kim, who's over at Duke. So this is a patient who had an impassable malignant obstruction of the common bile duct distally. After multiple repeated attempts, they just could not get to it from above or below after multiple attempts. And ultimately, this patient had only an external drain. So you can see again, the sheath is placed in the left-sided ducts. So the drain was on the left side, and this patient was in hospice. The drain hurt the patient. He couldn't breathe properly. The drain kept getting pulled out because the patient would roll over in the middle of the night. It was not the most ideal situation. So how do we get this patient tube free, right? That's the goal here. And so this patient underwent and he's not a surgical candidate anymore. He's a hospice patient. I believe that surgery, he was too old to undergo a hepaticojejunostomy or a removal of the tumor at that point. So this is where IR excels, right? These are the cases that we all love to get when someone comes down to our reading room and is like, listen, we have a case that's super difficult. Nobody else can help us. And that's really where IR started, and I think where IR excels, in my opinion. So here's this patient, and so Dr. Kim and his colleagues at Duke basically decided, look, this left hepatic lobe, which you can see here on ultrasound, sits right next to the stomach. And here's a CT correlate. And so they're like, we're going to take gastrostomy tubes. We're going to take a gastrostomy T-tac and basically pin the stomach to the inside portion of the left hepatic lobe. So that's what you can see them doing here. You see this echogenic needle that goes through the liver into the stomach. You deploy this T-tac and basically pins the stomach up to the liver. The reason that they wanted to do this is that they gained a second access from the right here, and then through and through, they went into the left hepatic lobe and used this device, it's called an RF wire, to burn a hole from the bile duct through the entire liver parenchyma into the stomach. And so you see this red arrow points to the tip of the wire in the stomach lumen right here. Okay, and you can see contrast that's injected after they had done that. So finally, once they did that, they deployed a VBX or a covered stent graft across this area. And here is a picture where they're injecting the right side. You can see it filling through the whole system, and you finally see that the entire biliary system is able to be drained via this stent directly into the stomach, right? This is something that surgeons cannot do. This is something that only IR can get creative and has the ability and the skill set to do. This is the reason that really, makes me get up and love going to work every day, is to know that this is the kind of stuff that IR does. Finally, the last case that I want to present in this whirlwind of biliary intervention is another new novel technique which is starting to gain traction. It's pretty common around the world, but it's starting to gain traction a little bit more here in the United States, which is interventional brachytherapy. This is where IR and radiation oncology work together for patients. So we deal a lot with patients that had advanced pancreatic cancers and who are not amenable to surgery. And these patients usually get an option to get radiation and chemotherapy. But external beam radiation therapy results in a lot of collateral damage because the burn radius, in order to get a sufficient dose deep enough, would have to burn portions of the stomach, the duodenum. You can get radiation gastritis, radiation esophagitis, things like that. So one of the things that we could do is brachytherapy, which is delivering a very, very high dose of radiation to a very small area. And if you really think about it, what Dr. Hoots had talked about, which is Y90, is a form of intra-arterial brachytherapy. That's exactly the same thing of what we do. But here, we're partnering with radiation oncology. We get biliary access through a PTC, as you can see in the top right corner here. We put a sheath down and basically drop brachytherapy catheters. And so along these black marks here are sources of emission of radiation. And so these catheters are hooked up to a radiation source on the other side, extrinsic to the patient. And you basically turn the knob and you can get very, very hot amount of tumor or hot amount of radiation dose to be given just around where the tumor is, but just millimeters away around the pancreas, around the common bile duct, you will have no radiation whatsoever, right? Another thing that you could do is actually here in this case, after doing this intraarterial intrabiliary brachytherapy, they deployed a stent. There's actually a company that allows you to take the stent and they embed brachytherapy seeds, very similar to when you have brachytherapy seeds inside a prostate, and they'll put it into the stent. And so interventional radiology can go down and deploy a brachytherapy stent into the common bile duct that allows you to open it up and deliver radiation source to the tumor itself. So you're not only treating the biliary obstruction, but you're actually also treating the malignancy as well. All right. So biliary intervention. So in conclusion, biliary intervention remains a tremendous technical challenge to interventional radiologists. It requires an appropriate amount of post-procedural management. The increased use of endoscopy for biliary tract evaluation and intervention has served to largely replace percutaneous techniques, but were absolutely still essential to a lot of these cases. And familiarity with normal and variant biliary anatomy and experience really helps you become an excellent source for your colleagues who are hepatobiliary surgeons, surgical oncologists, gastroenterologists, and for your patients. So here's a shameless plug of our hospital. You guys are just down the street here, proverbial street. And thank you very much.
Thank you so much, Dr. Shaikh.
Yeah, any questions?
I don't see any questions in the chat, but so we're gonna take a break. I think the next session is planned for 1:15. So if you guys just want to come back then.
Great. Thank you so much. Bye-bye.
Yeah, thank you.
I'm going to just touch on today. So uterine artery embolization, pelvic venous disorders, flipping tube recan, Nexplanon removal. Again, just a small note on the uterine artery embolization. I didn't put UFEs, right? I think traditionally everybody says UFE, but it's there's many more indications which we'll get into for uterine artery embolization than just fibroids. So I think I always mentally. I always have to like switch my brain to make sure I say uterine artery embolization, because it's much more than just fibroids. So, and of course, if I'm going to talk about uterine artery embolizations and UFEs, I've got to mention we'll talk about, so these are the different indications that we're going to go over. Fibroids, of course, adenomyosis, preoperative embolization, postpartum hemorrhage, and malignancy. And of course, if we're going to talk about fibroids, start with fibroids. Got to talk about the boss. So Teresa Caridi at UAB, her Twitter hashtag is the fibroid lady for many good reasons. And then for many of the reasons I'd already stated, I think she really does view this as a complete service line, has done a great job. If you ever have a chance to look at her clinic schedule, it's almost top to bottom women's health. So she does a great job of exemplifying that this is, it's just much more than fibroids, and you can be really a partner with OB and really have a standalone service if you do this well. So first thing we'll talk about is fibroids. So, why do we even care about fibroids? It's the most common tumor in women, very prevalent, 70% Caucasian, 80% African-American women by age 50, 50% symptomatic, most common indication for hysterectomy. So there's a huge population out there, and there's a huge population that's really just being untreated or honestly just not even offered our services, even though, this is a great treatment in general. I think UAB actually did a recent study looking at Alabama, the state of Alabama has a section of the state called the Black Belt, where there's just a huge underserved area for African Americans in the state of Alabama. And we actually had a paper looking at that, and that the UFIs are way underutilized in that area, and we're trying to change it right now. So that's why we care. Pros, of hysterectomy and myomectomy, it's a global treatment, really treats the whole uterus. It's uterine sparing, get to keep your uterus if you do this, efficacious. It's not 100%, but it's pretty good. And the short recovery time, we give our women usually a week. Sometimes people are on their feet earlier than that. They usually don't. They usually go home on the same day of the procedure and maybe an overnight hospital stay. But you compare that to hysterectomy, maybe myomectomy, and it's longer recovery time for both those things. So something to always keep in mind when you're talking to people. So the picture on the left is just give you a visual. We'll go over some of that stuff in a second. Just what these things look like and where they're located and some of the names. And then of course on the right is why we're here and talking about UFIs. And so, these typical cases, here we have Casey Freeman, fictitious character. She has some menorrhagia, she has some abnormal bleeding. She's 45, which is a perfect age for these procedures. She wants to wear white again. She just can't do it because she's worried about bleeding. So, this lady, she's close to menopause, most likely, which is great. This is, be very much, I think these patients are ideal when I talk to mid 40 year old women, because you really just bridge to menopause. Menopause, uterus shrinks, and so this is perfect candidate. All you have to do is get them there. She's a menorrhagia patient. She has abnormal bleeding. She has UFIs do really good on from bleeding indications. You got pretty much bleeding or abnormal bleeding and bulk symptoms. Kind of how you classify or break down the different symptomatology. And she's perfect. It's just it's the ideal candidate for me. So this is her MRI. Let's go over briefly T2 weighted image of it there. These huge bulky fibroids, post contrast on the right, shows pretty some enhancing fibroids throughout the uterus. They're pretty large and huge. Like I said, she was more bleeding than bulk symptoms, but I'll bet you anything if you asked her, she'd probably have some more bulk symptoms. So how do we do this? Access choices, people do a lot of different things. You do femoral, you do bilateral femoral, folks in DC do sometimes, or radial, really just user preference. My preference and Dr. Creedy's preference is groin, unilateral. So people do some different things, and it's completely fine or normal to do really any access you want. It's pretty much, we're going in there, we're going down the internal iliac artery or epigastric artery, going down into the uterine artery, and then past the little lateral segment. Usually it just goes a little, or can go a little further. I just refer to it as a lateral segment, because if you get some particles or whatnot going down that cervical vaginal branch, then you can have some pain issues. So have a bad time with that. So there you go. It's just kind of looks like a U there, right? So treat both sides. Treating the right side on the left side of the screen, and the right side or the left side on the right side of the screen. I was going to screw that up for this patient. So you get down there. We use embolics for this procedure, just particular embolization. It looks like PVA, I believe, in that syringe. topic for a different day, I guess. But yeah, so just little particles in there that just clog up the arteries of different sizes. We'll talk about sizes, I think, more in adenomyosis here in a second, but in certain sizes that work out well to occlude these arteries. Yeah, these procedures are great, really same day discharge. Like I said, there's 1,000 different ways to manage patients' pain. And that's the only thing that really holds these patients up sometimes. If I'm doing these procedures, I love to do in the morning, and then you really just wait till the afternoon to kind of evaluate if I'm going to admit them overnight or not. I think most of them do go home. They're only a week off of work, as opposed to like a hysterectomy would be much longer. And we usually like a 2-week follow-up in clinic, and then just kind of a, hey, how's it going? Anything problems, groin check kind of thing. And then we do, more comprehensive visit about 3 months later with an MR if insurance will allow it. And so what are the results for these things, right? I mean, like, you can kind of see them, let's say maybe 50% debulk on that, right? So, I have those huge fibroids on the left side of the screen, and much shrunken down versions over on the right side of the screen. This one isn't post contrast, but clearly it's a great result on this one. And this is the post contrast. So on the left side, pretty avidly enhancing, on the right side, no enhancement almost whatsoever. Great result. Lady was able to, I know the actual case, not the fictitious name, but yeah, she had a great result. She had no more bleeding problems, resolved within a week or so of the procedure, and she made it to menopause, and everything's going great for her. So just a brief on some of the misconceptions of like why we don't want to do it. Honestly, I think that most patients are great candidates for this, and there's all these misconceptions as you rotate through your OB-GYN or family medicine or whoever might be managing these things. And in the community, there's all these like things we talk about, right? So fibroid location, people talk about submucosal fibroids or pedunculated subserosal. It's on an MRI report, but like you can't send an IR because of the location. It's like a lot of times just let us make that decision a lot of times, but there's reasons for it. Slightly increased risk of endometritis and things like that. If it's pedunculated, you might get expulsion of fibroid products, right? So it goes out through the vagina, which always it's more of just a talking to the woman in clinic or whatnot on what to expect afterwards. Fibroid size, like I said, great for bleeding. Will maybe debulk by like 50% or so, but sometimes people say, well, it's too big. Well, I don't think anything's too big, honestly, and as long as you get symptomatic relief from whatever you're trying to treat. So again, maybe a conversation with them if they're in bulk symptoms, but you still can get great results even if it's a enormous fibroid. And fertility, one of the biggest, my questionnaire, for at least my mental questionnaire for all these patients, are fertility, right? It's like, this is not a contraception, right? This isn't like you have a UFI, you won't get pregnant. Like, it's definitely a conversation with them. A, if they do want future pregnancies, because they can, and then B, like if they don't, we need to do other things outside of the UFI, of course. Play your hand risk like that. Okay. So adenomyosis. So this is some of them. We're just going to blow through some other indications, and don't want to use this time effectively. So adenomyosis. Here's an example of adenomyosis. This very like contrast enhancing uterus in the middle, very dark on T2. This is diffuse adenomyosis as opposed to some of the other varieties, but this is a great example here. This is like post. This is after embolization. Like, just look, there's less bleeding, or it's shrunk a little bit. It's definitely not as avid and whatnot. And patients do pretty good with symptomatic relief. Different protocols for this. So this actually, we talked about particle size a little bit. So for fibroids, use a little bigger. For these, use a little smaller, because it really does, smaller particles will higher likelihood of maybe a higher degree of necrosis. So symptom improvement is tied to degree of necrosis. The smaller particles, the better. There's like this famous paper, maybe one of the original ones, this 3-2-1 protocol and whatnot. With PVA, we'll get into details of that, but it usually means you need to bump it up a little bit with some modern particles, but yeah, so long story short, smaller particles for adenomyosis and pretty great clinical results. So what do I do when I tell my patients or talk to my patient about adenomyosis? It's really compared. There's really no like comparison with other treatments, direct comparisons, but you do get great symptom relief from this, 85-90% symptom relief. It's not, a lot of this stuff isn't maintained in the long term, but very good relief in the short term. You can use an ID to help improve the symptoms as well. And I think with anything, for even fibroids or for adenomyosis, this doesn't really preclude anybody from different treatments down the road. If you do want a hysterectomy down the road, you're more than welcome to get a hysterectomy, and it won't like affect anything, which is sometimes people don't realize that when they talk to you. So about other things, we talked about, there's like a big nasty uterus here is T2. This is your post-contrast here. It could very lobulated, could be cancer, could not be cancer. I don't want to touch it. Honestly, it's huge, right? We kind of talked a little bit about hesitancy from some people to do the big bulky ones, right? So yeah, so for this one, maybe not that I think OB wanted to, or Gyn wanted to take this out, but they were worried about bleeding as it's so big, so avid, so whatever. So, they asked us to take care of it. So we did. And this is what it looked like. This is the first image that we saw. I mean, these things are a huge, big, nasty thing. So, it had little blood loss. Don't remember what the blood loss was, but they definitely congratulated us on that. So there you go. Postpartum. Next for at least uterine artery embolization, postpartum hemorrhage. I'm going to blast through this a little bit, but I always think this is a great way when you get out in the real world to like really get to know your OBs and have them send you maybe some of their clinic patients for fibroids or whatever it might be. I've had a couple of these where same OB, and I just talked to them and they go, we can do this, not in this like emergent situation as an outpatient for some of your fibroid patients if you would like. So save a life or two from OB, they start sending your fibroids remarkably. So 2 types, early, delayed. Primary, this is like right after, I forget what it was, probably C-section or whatnot. So, just bleeding, artery, bleeding out, whatever, we went in there, we just embolized it, use some gel foam or whatnot. The secondary things, the uterine AVM, again, just went in there, I think gel foam this, just let it heal up. You can see like the serpiginous, on that second image, you can see this like serpiginous vessels down there, kind of indicative of that. And just, you want to let the body heal a little bit. So a little gel foam down this. You use a lot of different things. I personally use gel foam for this, just to, again, save a life a lot of times with bleeding. This is what it looks like on angiography. And of course, like malignancy indications as well. Had a rash of these recently where, just cervical bleeding or endometrial bleeding or whatnot that they just can't control, so they ask us to go in there and do things. So we go down there, you kind of see these little tiny squiggly things here. So these the malignancy ones are actually gonna be a little more difficult, more like maybe prostate, which I think we're going to talk about in a little bit. But they can be a little harder to get into and harder to treat just based on the squiggly or the size. Really, it's not like those big bulky things from big masses, but from malignancy, they're usually kind of tired. Like older women, smaller uterus, a lot of times, it can be kind of harder, but definitely treatable. Sometimes you can just gel foam or just blast it from internal iliacs if you can't get into what you think is bleeding. Brings us to the second. Trying to check on time. I'll try to hurry. Sorry. It's like we're not going to get to a couple things, but so pelvic venous disorders is another thing that we offer on the service line for women's health. It's really chronic pelvic pain. It's like 31% of pelvic pain in women, dilated veins, and release these neurotransmitters, that kind of thing. Used to be have these different kind of categories or reasons to have it. It used to be like PCS or pelvic congestive syndrome is what we like to call it, nutcracker, Mayther, that kind of thing, and just the individual things. But now it's kind of like terminology's changed a little bit. We talk about venous insufficiency and bowel deficiency and or venous obstructions from that renal vein, from the iliac, that kind of thing. So terminology and thought process behind the stuff is changing, but these women get great results. There's the imaging, clinical presentation, pain for greater than 6 months, non-cyclical, dull, achy fullness. You see this a lot on dilated ovarian veins, pelvic veins, that kind of thing. It's really works. All these things. So on the y-axis, you see the pain scores. On the x-axis, you see months for embolization. There's all these like great papers that show that we really do a really good job. It's one of those things that insurance companies love to not pay us for or not approve, because there hasn't been any randomized control trials for these things. But all the women I've done, I think I've maybe had one that wasn't successful. I've just praised these procedures and love them. So Alabama's really hard to get it. Tennessee was really good to get it approved. I don't know what it's like in Florida, but it's great. here's just a case of it. This is like how, you start bringing things together, and it's just not one process. It's just not in the Varian vein. It's a bunch of different things. So, usually if I have one of these patients, I'll start off with a Varian vein embolization and sclerotherapy, which is what you see here. Some sclerotherapy, so you're up and over on the left side, doing some runs, looking at all those nasty collateral veins down there, and then do some sclerotherapy in the middle. And then usually do kind of a sandwich technique with STS and I think coils and plugs here and whatnot. Then go over to the other side and do the same thing. And then I think usually I break it up into a couple procedures if necessary. Same back in clinic, see what the symptoms are like. If the symptoms are better, then that's great. If they're not, like this patient, I think actually on the original one, or at least on the CT, I saw that the probably May 3rd anatomy or whatnot. But a lot of times just want to give it a chance. So we came back, we looked at that and used IVUS, so intravascular ultrasound here. So you can see there's a pretty significant narrowing there as the artery crosses the vein right there. There's the IVUS catheter right here, this little mark thing there. And so we decided to stent the patient, which is great. Clinically, a couple weeks later, follow up, no more pain, doing great, and clinical success, which is great. Make sure we're kind of running out of time here. I'll kind of just finish this one up and let the next speaker go. But so this is, one of the things that is the most challenging thing about this is not really procedure. It's really easy to do, but it is very hard sometimes to get it approved. So, I think that's our template over there on the right, Dr. Creedy's name on that. But it's just, it's hard to get through sometimes insurance, especially in the state of Alabama, which we're working on. But there's only one comparison study that, I'm aware of. It doesn't affect postmenopausal women, and maybe so let's just do a hysterectomy, right? So it's just like hysterectomy. You'll see this a lot. There's a lot of options that we can offer that's even for that. And I think this is probably
that. Okay, let's see. All right, so why do I say that? So uterine fibroid embolization started around 1997, started in United States 1999. And exactly 10 years later, prostate artery embolization started kind of like, initial trials, animal studies in 2009. And by 2011 is when it kind of made its way to United States. All right, so these are my disclosures. We'll go through some basics in terms of, as we know, BPH is extremely common, and that's what, PAE's main application is, apart from hematuria and then some upcoming trials in space of prostate cancer. But the main application remains treating lower urinary tract symptoms related to BPH. And as we know, the incidence of BPH is pretty high. 50% of women, 50% of men above age of 50 and 70% of men over age of 70. Will have some symptoms related to BPH. Some underlying basics, pathophysiology, which I think is important for us to understand and put into context. So there are two different components. So when the prostate enlarges, one is the static component, one is the dynamic component. Static component is really just simple enlargement of prostate with increase in epithelial and smooth muscle cells. Dynamic component is increase in the smooth muscle tone and resistance from the enlarging gland, as well as it's mainly at the bladder neck area, which is where the alpha blockers work. And then bladder response, which is the secondary response of the urinary bladder, as you can see when it's obstructed, can be more of a distended bladder with the wall thickening. And this may produce a number of voiding symptoms termed lower urinary tract symptoms, which can be broadly divided into storage symptoms, voiding symptoms post-micturition. Storage symptoms include frequency, urgency, nocturia, and incontinence. Voiding symptoms is slow stream, splitting stream, intermittent stream, hesitancy, or straining. When you plot these major symptoms on a symptom score scale, from 0 being not at all to 5 being almost always, 7 of these different symptoms ranging from 0 to 35. 0 to 7 mild, which really doesn't need any treatment, which is really the target. When we treat patients, we want to bring them to this 0 to 7 category. 8 to 19 is moderate, and 20 to 35 is severe. Most of the treatment is offered 13 and above. So symptom score of 1, 3, 13 and above, and quality of life of 3 and above. So dissatisfied, unhappy, or terrible, which is a urinary quality of life based on their current symptoms. So very quick note, that BPH or BPO, which is benign prostatic obstruction, is not the only thing responsible for your lower urinary tract symptoms. So clinically, you have to always rule out other issues also, or other underlying pathology like overactive bladder, nocturnal polyuria, detrusor underactivity, neurogenic bladder, etc., etc. So, we always make sure that we are treating the right patients. So if you take a cohort of men more than 40 years old, histologic BPH remains pretty common. I would say around 50%, and then lower urinary tract symptoms, half of those patients, and then you have to get prostatic enlargement, infravesical obstruction, and this is the group which will require treatment, starting from conservative to medication to minimally invasive options to surgery. A couple of other things which are done in terms of workup is very simple, which is a flow test, which is essentially patients pee in this like a funnel-shaped cup, and then you measure the flow rate. Less than 10 ml per second is considered to be predictive of bladder outlet obstruction. A post-void residual, which is how much they are retaining after each voiding. More than 50 ml is significant. More than 300 ml is an important number for chronic retention. Baseline MRI. Well, we are interventional radiologists, so we like to see what we are treating. So baseline MRI we do for a lot of different things, including looking for any asymmetry, how big the prostate is, median lobe, protrusion into the bladder, health of the bladder itself, the size of the median lobe, which is exactly the protrusion, rule out any cancer. And then we also look into how big is the transitional or the BPH zone compared to the peripheral zone. Current standards in management of lower urinary tract symptoms include many surgical options, including simple prostatectomy to HoLEP, which is a type of laser, to minimally invasive things like Resume and UroLift, which are relatively new. So this is, you see, essentially a TURP, which is the gold standard for smaller glands, and then laser, which is kind of gold standard for larger glands. Very similar procedures. This is cutting, this is vaporizing, but just to put in perspective what we are dealing with in terms of standard of care, or you can say that, what we are competing against. Again, as I said, TURP remains gold standard. You're visually getting the tissue out, done by urologists. Tissue is sent for pathology. Pretty good long-term satisfaction, flow rates, and then decreased morbidity compared to open prostatectomy. What are the outcomes after a TURP? Very important, because everything is benchmarked. This is the gold standard. So whatever new procedure comes in has to have an RCT against TURP, or all the comparisons are against TURP. So what's the goal, or what are the outcomes from TURP? Symptom score, which is the IPSS score we looked at, decreased by 70%. Quality of life decreased by 70%. We looked at the flow rate, which was less than 10. Was diagnostic, increased by 125%, and then post-void reduced by 77%. So these are the four major parameters which are always followed, and then retreatment rates around 12% at 5 years. To put into perspective, we are looking at around 20 to 25% retreatment rate at 5 years for PAE. Very similar symptom score improvement and quality of life improvement with PAE, which are like, kind of take-home points, but the Qmax improvement is only 50%. PVR improvement is only 50%, but these two are 70%, very similar. So what's the issue with current options, the surgical options? Not only the need for urinary catheters, sometimes bleeding, requiring continuous bladder irrigation, need for hospitalization, retrograde ejaculation and erectile dysfunction are long-term side effects, which most patients do not want. And then risk of incontinence or urinary stricture. Incontinence is essentially leakage. So because of these 3 or 4, patients try to avoid TURP. There's like, I would say, millions of men who have been waiting for something else, but not to get a TURP done. They call it like Roto-Rooter on internet for multiple reasons. And so where does PAE fit in? It's, as I said, it started in 2009, 2010, Brazil and Portugal. Fibroid started in 1997. Now, 12, 13 years later, PubMed has 700 plus articles, FDA approval since 2016. This is my estimate. Over 25,000 patients have been treated worldwide. The learning curve is around 25 cases. Procedure time is around 90 minutes after you have done around 100 of these. Risk of non-targeted embolization is less than, which is the particles going anywhere else. I'll address that in a second. Is less than 0.5%. My personal experience, I've treated over 1,200 patients myself. So rationale, BPH, you saw that nodular enlargement of the prostate. It's a hypervascular condition, should respond to embolization, which should lead to ischemia, reduce size, reduce consistency, reduce hormonal action, which can lead to urethral decompression, reduce smooth muscle tone, disease progression, and then ultimately improval of urinary flow, symptoms, and quality of life. So on the left side, you can see a pre-procedure or a pre-PAE MRI. On the right side, you can see the two central kind of areas of necrosis in the central gland or the transitional zone after embolization. And this was, I did this a pre-prostatectomy study. So you can see I have even the explant where you see nice kind of areas of necrosis in the transitional zone. And all these particles are lodged kind of in the periphery. These are the embolic particles and the necrosis volume of around 30%. So let's look at some clinical aspects. Outpatient procedure, patients go home literally within 45 minutes to 2 hours after the procedure, depending on radial access versus femoral access. I do most of my procedures through radial access. I initially started with femoral. So out of 1,200 patients I've treated, I would say around 1,000 have been radial and then 200 have been femoral. Obviously, fluoroscopic guidance, more than 97% technical success rate. No need of Foley catheter. Animation showing how a PA is done. So you put a catheter. This one is through femoral access. Go to internal iliac, very similar to what we saw on the UFE. And then you put a micro catheter all the way subselective just into the prostate. And once you confirm the position, then you inject these small particles, which are essentially made up of polymer coated with gelatin. I'll show those more details of those particles in a second. And essentially you are depriving prostate of the blood flow. Some basics of anatomy. You're looking at ipsilateral oblique angiogram. And in this one is the prostatic artery. This is obturator, internal pudendal, inferior gluteal. And this is an inferior vesical origin. So the types of origin, one is inferior vesical. It can be internal pudendal origin, or it can be obturator origin. So these are the three major types of origin. But essentially, it can come pretty much from anywhere. This comprises around 95% of origins. And then you obviously have to target the urethral, periurethral, or the transitional zone branches, because that's the BPH zone. Peripheral zone branches, you can target those if you can, but I usually don't waste a lot of time hunting after those. So that's the transitional, that's the peripheral zone supply. Once your catheter is in there, again, what we saw on the animation, you are delivering this particle slowly into the prostate. The target is, we mix these particles up to 20 ml of mixture. And if it's a 100-gram gland, then we will try to put 10 ml of that mixture on each side. An important thing for prostate is doing what is intra-procedural CT scan to confirm that your position. This is only with contrast. So before you start embolization, you want to confirm that the distribution of the particle is only within the prostate or the hemiprostate and not anywhere else. This is the nightmare. The technical aspects. You really have to make sure that none of these particles go into, especially the dorsal penile or the rectal or the bladder branches. But again, the risk is 0.5% here. So these are the particles which we use, or these were the first ones to get FDA approved. These are spherical permanent embolic called trisaccharyl gelatin microspheres or embosphere microspheres. The other ones are spherical PVA. So these are hydrophilic surface non-aggregation. Compressibility is around 33%. And then size range is what we use is 300 to 500 microns in most of the cases. So what happens after the procedure? You do the procedure, you embolize the prostate. Patients do fantastic. They don't feel anything during the procedure. After the procedure, they don't feel anything. Once they go home is when they will start having burning urgency, some fatigue, bladder spasms, mild to moderate pain, and mild blood in stool or urine, essentially post-embolization syndrome. They usually recover by day 5. Benefit begins at 2 weeks post-procedure, significant improvement at 4 weeks. Peak benefit at 3 months and then remains persistent. So let's hear from a patient.
It's been just 2 weeks since my procedure, and I can tell you I am a different person now. The first time, actually, I got on a plane on Friday, just 10 days afterwards. I didn't have to get up off my seat on a 3+ hour flight. It was great. Anyway, basically, you really prepared me well. The first 5 days, yeah, you had the cramping that started to go away. The burning was probably the last thing that stayed. And by 7 days, I was already I felt the change. After 10 days, the change was even more rapid. And I feel like I said, I'm a new person. My definition of urinating was stop, dribble, stop, start, all kinds of random, all kinds of a few hours in the middle of the night. Now it just start and stop, and I'm done for the.
So this is like a classic index patient. Most of the patients do the same. They recover by day 5, day 7, and then they see significant improvement at 2 weeks. In terms of post-PAE adverse events, what I mentioned, the burning urgency remain the most common one. In interest of time, I'm going to move forward a little bit quickly so I can show like the current data and everything. This is the nightmare. We do not want this complication. From 1,200 patients I've treated, I've seen this 4 times, and it's not pleasant for the patient or yourself. But fortunately, all 4 of them healed with just steroid cream and lidocaine cream, which is a non-target embolization to the tip of penis causing a penile ulcer. Another classic kind of patient. This is how the patient will present. 62-year-old male. Many of them will have had a previous already a surgery or another procedure. IPSS score of 28, uroflow of 3 ml, PVR of 170, and look at this huge giant gland kind of growing into the prostate with 380 cc. So put into perspective, less than 50 ml or 50 cc is normal prostate. 50 to 100 moderately enlarged, more than 100 significantly enlarged. Most of the urologists really do not want to deal with prostates larger than 150, and that's really kind of like where I come in and most of my practice comes from. So this is a larger gland. You get selective, you do the embolization, confirm on the CT scan, and at 3 months the prostate has gone to like literally half the size. IPS is down to 6, quality of life to 0, and I just saw this patient in a 4-year follow-up. So evidence in LUTs, really, when you look at intervention for BPH, the absolute indications are urinary retention. Patients do present to us with like complete blockage, recurrent UTIs, renal insufficiency, gross hematuria. These are like advanced patients. And then moderate PVR, just like what we saw, the post-void of more than 300 or moderate or severe symptoms. When it comes to PA specific, poor surgical candidates, failed surgical procedures, larger prostate, acute retention, hematuria, and men wishing to avoid sexual side effects. These are like the key groups we treat. Where I do not offer PAE is small prostate size, less than 50 gram, large, medium, low. Now this is a little bit not written in stone. So the one which I showed just now was a little bit larger, medium, low, but it was very symmetric. So that's why we still offered. But if it's a figure of 8 and a very large median lobe, then I usually do not offer PAE because of a high failure rate. Predominantly irritative symptoms, which is they have overactive bladder, very high PVR with no symptoms, which means they are not feeling anything. That means they have a detrusor underactivity. And then severe peripheral arterial disease, no vascularity, no embolization. And then compromised detrusor contractility, which is similar to what we saw, high PVR with no symptoms. So if you look at the paradigm for surgical therapy in the BPH world, TURP, HOLEP, gold standard, lead to 70% improvement in the symptom score. But when you look at effectiveness, great. Tolerability, not that great. Patients don't like it. Why? Because of this risk of EJD or ejaculatory dysfunction, erectile dysfunction. So, as the procedures become less invasive, which is like, say, now you're looking at 50% improvement in the IPSS score, less invasive procedure, office-based steam procedure, only 4 to 16% risk of ejaculatory or erectile dysfunction, then the tolerability goes up. So patients really kind of look into, okay, what's the risk of sexual side effects? And that's where PAE is fantastic. It's as effective as TURP or HOLEP. No inpatient, no Foley, no incontinence, no stricture, no EJD, no ED, and promising retreatment rates. So that's why when patients hear about this, they want it. So what are the expected outcomes? 85 to 90% success rate, 50 to 70% reduction in IPSS score based on which literature you look at, 90% success of removing indwelling Foley, 90% success resolution of hematuria, 30 to 40% reduction in prostate volume at 3 months, and durability of 75% at 5 years. So there's a Cochrane review which kind of summarizes all the studies till date, and that's a PAE versus TURP short term at 12 months and long term at 24 months. And it says there may be little to no difference in terms of symptom score improvement between PAE and TURP at 12 months. So very, very important. Again, this I'm not going to go through individual trials, this summarizes everything. And quality of life, same thing. Major A's, we are very uncertain, but we know that PA is extremely safe. And PA probably increases retreatment rates. That's absolutely true. Long-term remains the same. No little difference in the symptom score. Same thing with QOL. And then retreatment rates, yes, they're going to be a little bit more. Like I showed 12% with TERP, this is going to be more like 20 to 25% with the PAE. Meta-analysis using random effect meta-analysis, no significant difference between PAE and TERP was observed in IPSS score, QOL, or the sexual function and post-void residual. This is one sham study, 39 PAE, 38 sham, which showed clear superiority of PAE over sham. PAE and erectile function, this we published like, a summary of a meta-analysis of all the different studies out there. And we found like basically it has no impact on the ejaculatory function and minimal impact, if any, on erectile function. Up to 85% of patients will have no or positive impact from PAE. And that positive impact is due to stopping medication, not due to PAE. When it comes to the societal guidelines, AUA guidelines still does not endorse PAE for routine treatment and is not recommended outside the context of clinical trials, but we are still constantly working with AUA to get this updated. SIR does accept this as a minimally invasive treatment option for moderate to severe LUTs, especially for large prostate glands, more than 80 grams, acute or chronic retention in setting of preserved bladder function, which I highlighted before, and patients who wish to preserve erectile or ejaculatory function. So where does PAE belong? Really in the large prostates, it has a very, very, very important role to play. And maybe in average size prostate too, in non-surgical candidates, larger prostates more than 150, and again, patients who wish to preserve erectile function. And so just a little bit about me. I mean, I've been doing this for since 2011. I can safely say probably I have the largest experience in United States as an individual. And just another highlight is that this year's Society of Interventional Radiology, we are going to present our experience of 1,000 patients in the plenary session. And I want to acknowledge and, appreciate all the urologists I work with. I work with, I would say, close to 100 urologists in Southeast Florida and Southwest Florida. And I also want to acknowledge Dr. Parikh, who is professor and chair of urology at University of Miami, who has been a big supporter of this. So thank you very much for having me. Thank you for your attention. And please feel free to reach out to me if you have